your time, we can
Yeah.
start and people will come. Or
Yeah.
we
We
cannot.
wait, I mean,
We have the same.
Yeah, no, as long as they are not all like in the foyer.
The foyer there are almost.
no,
I mean, there are some, but they are
some.
having their juice and whatever. So we're starting, then people are joining.
Yeah.
Some food they put to the poster.
No, just wait like one minute. No, it's not.
Okay. To Matthias, to have a street very.
Yes, I told them. Yes. Ouais, l'image Azmed, la presse, là, c'est non. Okay. Good morning. Is it working now? No. I don't know where the mic for the students. 1, 2. Test. Working. Okay. Oh, no, it's working. Good morning, everyone, for this second day of MIDL. So here you see the program of the day. Just quickly a few reminders. So you've just received an email from like the MIDL board reminding you that all the presentations are live streamed and will be available online after the conference. And also to remind you that there is a job board on the MIDL website. So if you want to add something, then you have all like the information on the email you received. So here's a program of the day. So 3 oral presentation sessions, sponsor event, 2 poster sessions, and at the end of the day, the gala dinner. So the gala dinner is at 7:30. Later in the day, we will like give you like the details of how to get there, but you should already have them. They're on the website, they're on the leaflet that we gave you. Last point, if you didn't take down your poster yesterday, it's close to the reception desk. And so please, at the end of the day, don't forget to take them down, otherwise we will do it for you. And I think that's it. So now it's time for like the first session of the day on clinical translation and domain adaptation.
Good morning also from our side. My name is Philipp Behrens from the University of Tübingen.
And I'm Matthias Heinrich from the University of Lübeck.
So the German session in the morning. Without much further ado, so the session will be on clinical translation and domain adaptation. And without further ado, I would like to introduce the first speaker of the morning, which is Roman Dutt from the University of Edinburgh, talking about parameter-efficient fine-tuning for medical image analysis.
Good morning, everyone. My name is Raman, and today I'll be talking about our work, parameter-efficient fine-tuning for medical image analysis, the missed opportunity. This is a joint work with my collaborators, Linus Eriksson, Pedro Sanchez, Soterios Saftaris, and Timothy Hospitalis from the University of Edinburgh. So in recent times, we have witnessed a lot of these models called foundation models. Every other week, there's a new foundation model in the market. The most common ones being the GPT family. Recently we have also seen the Llama models, Clip, DALL-E, Stable Diffusion, Imagen from Google, and Segment Anything, which is fairly popular in the medical community as well. So in a general term, a foundation model can be defined as any model that is trained on broad data and can be adapted to a set of diverse downstream tasks. This requires a common training recipe. Firstly, foundation models have a billion parameter scale. You would see that most of the models that we have, or most of the models that I've shown in the figure, have more than a billion parameters. Second is the scale of data. Foundation models are usually trained on large or huge amounts of data that contain billions of samples. So there's an issue that foundation models often lack knowledge about specialized domains such as medical images. And this was also seen with the segment anything model. When people tried to apply it to medical images, there were a lot of issues with it. So this leads us to a requirement that foundation models are powerful, but they need to be adapted on domain-specific data, such as any type of medical image. Now, there are different strategies to adapt a foundation model for our downstream task. The most common strategy that you might have seen is full fine-tuning, where we take a pre-trained model and we update all the parameters of that model on our target data set. Then there is something limited fine-tuning or linear probing, where we freeze the encoder of our model and we just fine-tune a classification head on the downstream data set. And there are some other strategies which don't require any fine-tuning at all, such as when we are doing retrieval or clustering. However, each of these strategies have some kind of challenges associated with them. When we do full fine-tuning, there's often a case of overfitting or catastrophic forgetting. And this is mostly because when we are doing full fine-tuning, we are updating the entire parameter set of the model. This model contains billions of parameters. Data sets, especially medical data sets, are small, which is a great recipe for overfitting. If we do limited fine-tuning, we have often witnessed performance degradation. Limited fine-tuning has barely been able to reach the performance that we get by full fine-tuning. And if we don't do any fine-tuning, there's inadequate generalization in out-of-domain settings. So here comes parameter-efficient fine-tuning. The core principle behind PEFT is quite simple. We take a pre-trained model and we keep it frozen, and we fine-tune a very small parameter subset in this frozen model. Freezing the original model preserves the original capabilities of the model, and fine-tuning a small parameter subset provides additional capabilities while leveraging the original knowledge. So we are preventing both the things. We are not forgetting the original knowledge that the model learned, and we are also giving it additional capabilities to perform well on our data set. So let's visualize this with a small example. Imagine there's a fine-tuning spectrum. On one end of the spectrum, there's full fine-tuning, where we are adapting all the parameters of the model. And on the other end of the spectrum, there's limited or no fine-tuning, where we are adapting almost no parameters of the model. So PEFT lies somewhere in the middle, more towards the left side, where we are adapting very small number of parameters in our model. So talking about some of the motivations for our study, we wanted to answer we asked a few questions. The first question was, do PEFT methods offer performance gain for medical tasks? Because most of these PEFT methods are evaluated on natural imaging datasets, and we wanted to make this question. Second question is, given the wide variety of available PEFT methods, how do we select the best one? For example, if you're using a CNN or a VIT, which PEFT method is the best for that? or if we are doing image classification, or if we are doing some kind of a generative task, what should be our go-to PEFT method? And finally, PEFT methods are continuously being introduced in literature. So with new methods being introduced in future, how would we evaluate and compare them? And doing this benchmark exists in general computer vision, but they do not exist in medical image analysis. So that's why we designed this study to fill in these gaps. So a few characteristics of the study. We experimented, or we included 16 state-of-the-art PEFT methods. We included 6 medical datasets ranging in different size, modalities, and complexities. We included models from 2 architecture families, CNNs and VITs. We performed our evaluation on discriminative and generative tasks. And this, a combination of all these things, PEFT methods, datasets, architectures, and tasks, resulted in close to 700, or in fact more than 700 controlled experiments. And we addressed 3 main questions in this work. First is, how effective is PEFT for low data scenarios? Second, can PEFT improve performance in discriminative tasks? And third, can PEFT improve performance in generative tasks? We experimented, we included the following methods, the following PEFT methods or fine-tuning strategies in our work. Specifically talking about CNNs, full fine-tuning and linear probing are the conventional strategies. Then we use something called task-specific adapters, which is another PEFT strategy. Batch norm tuning, which is tuning just the batch norm layers in your CNN model. Bias tuning, as the name suggests, just tuning the bias layers. Scale shift features is another recently proposed PEFT strategy. Then some methods for VITs. Again, first 2 are just standard conventional strategies. Then we have something attention tuning, which basically means tune just the attention layers in your transformer model. Layer norm tuning, similar, tune just the normalization layers. Bitfit is tuning just the bias layers. Adapt former is another PEFT strategy for image and video tasks. Then the most common PEFT strategy you might have heard about is low rank adaptation, or LoRa. And finally, we used scale shift features, SSF, again in this for VITs. Now talking about some of the datasets that we used. For the task of image classification, we used the following datasets: breast ultrasound, Fitzpatrick, HAM 10,000, SMDG, pneumonia. And you can notice that these datasets widely range in their size. So we experimented with datasets from with a size of 580 samples to 20,000 samples. Now for the task of text-to-image generation, we use the Mimic CXR dataset that contains 110,000 samples. Talking about the results, evaluation on discriminative tasks, specifically image classification. We designed a very simple experiment to see how effective is PEFT in low data scenarios. So if you look at this figure, and if you look at the first figure, for example, on the x-axis, we have denoted the percentage of dataset we have used during fine-tuning. And on the y-axis, we have denoted the performance in terms of F1 score. So what we did in this experiment, we took 3 different fine-tuning strategies. In red, we have full fine-tuning, which is the most conventional one. And Bitfit and LoRa are 2 PEFT strategies. And we just kept on decreasing the size of our fine-tuning dataset and recorded the performance at each level. So at 100%, 80%, 60%, all the way down to 10% and 1%. We did this for, on the left, this is shown for VIT base, and on the right, it's shown for VIT large. So if you notice in this plot, specifically in the first plot, there comes a point where full fine-tuning is outperformed by Bitfit and LoRa, which are PEFT strategies. And beyond that point, full fine-tuning just consistently performs worse than our PEFT strategies. And we defined this point as a crossover point. So basically, there comes a point where, specifically if we go towards the low data regime, we see that PEFT strategies become more dominant as compared to conventional fine-tuning strategies. So when sufficient amount of data is available, full fine-tuning does perform the best, as we can see in both of the plots, at 100% dataset used. But PEFT methods do dominate at lower data volumes, and different PEFT methods can have different crossover points. So for example, in the rightmost plot, we see that The crossover point for LoRa comes much earlier than that for BitFit. So the next experiment was we wanted to study if PEFT can improve simple medical image classification. So we have shown in the two plots, the left plot is for VIT base and the right plot is for ResNet 50. And again, we are denoting the performance on y-axis, and on x-axis, we are denoting the number of parameters we used during fine-tuning. And from a simple observation, you can see in the first plot, you see full fine-tuning is this big circle. The marker size also denotes the parameter count. But full fine-tuning is a big red circle, but it does not lead to that strong of a performance. But towards the top left of the plot, you can see methods like LoRa and SSF. They do give a very strong performance, and they fine-tune very small number of parameters. You can just see that, compare it with the size of the marker. And it's the same case for CNN-based models such as ResNet 50 as well, which is shown on the right. So some key observations were both CNNs and VITs benefit from PEFT for medical image classification, and different architectures benefit from different PEFT strategies. So for example, we found that SSF is the best strategy for ConNets or ResNet 50 in the right, and LoRa turned out to be the best strategy for VITs. And benefits of PEFT are maintained across different pre-trained encoders. So these results are shown for an ImageNet 21K pre-trained VIT and ResNet. But if we change the pre-training to MAE or CLIP or any other kind of pre-training, we see that PEFT methods still dominate. Finally, we performed an evaluation on a generative task, which is text-to-image generation. So in this table, we can see that we have noted the FID score, which denotes the performance, which denotes the generated image quality at different levels. So in the first row, we have denoted FID for 110,000 samples, which was our entire data set. In the second row, it's for 50% of the data set or 55,000 samples, and then for 11,000 samples. So we just wanted to compare how the results change when we change the size of our fine-tuning data set. And in the columns, you can see that we have experimented with different strategies to fine-tune a stable diffusion model. So full fine-tuning, attention tuning, bias, normalization, bias plus norm plus attention, which is basically tuning all three layers together at the same time. LoRa, SVDiff, and difffit. These are some of the PEFT methods that are specifically proposed for text-to-image generation. And if we just see very easily, if we see the performance of full fine-tuning, if we see the average rank, full fine-tuning ranked 7th. Bias tuning gave us the best average rank, and some other methods gave us some other average ranks. But basically, the most conventional fine-tuning method, or full fine-tuning, ranks pretty badly. And some key observations was that, again, PEFT can improve performance for generative tasks as well. Methods performing well for discriminative tasks might not perform well for generative tasks. So if you remember from the previous results, LoRa was one of our best performing methods, but in this case, it's the worst performing method. And finally, full fine-tuning consistently performs worse than PEFT across all data volumes. So concluding, we established the first benchmark for evaluating and comparing different PEFT strategies using the most common medical datasets for medical image classification and text-to-image generation. We demonstrated that PEFT can improve performance on discriminative tasks such as image classification and generative tasks such as text-to-image generation. If we specifically talk about the results, LoRa was the best results for PEFT method for VIT and SSF for CNNs. And there is no single dominant PEFT strategy for all tasks and model architectures. So this work indeed showed that PEFT is a missed opportunity for medical image analysis. Thank you very much.
Thank you, Raman, for this presentation. Questions from the audience? Already several up there.
So I'll just repeat the question. The question is how many seeds we use in our experiments. So in the experiments where we were decreasing the size of the data set, so for example, in this experiment specifically where we are decreasing the size of the data set, the results are reported across 3 different seeds. But when we were using the entire data set, we didn't experiment with seeds. So it is possible to use LoRa for CNNs as well. It's just that people don't use it, but it is possible. LoRa is basically you decompose the weight update matrix. So you can perform LoRa for any layer. It can be a linear layer, a conv layer, or an attention layer. But when the original paper came out, they were performing their experiments on transformer-based models, and they found that doing LoRa only on attention layers gave them the best performance.
Okay, maybe another question? The woman in red?
Yeah, good. It's working. Hi, thank you for your talk. I was wondering, so if we place ourselves in this scenario, so the classification and the IT, do you really see the same effects of all the methods across data sets? And the following question is that if a data set is further away, quote unquote, than the one you pre-trained on, would you recommend using a method that is maybe like changing more weights or having, you know?
So, can you remind the first question again? Sorry.
Do you see the same ranking of the methods across all data sets for a task and architecture?
So, yes, all the results that we have reported were for average across all data sets. But even if I look at one data set at a time, the trend remains the same in most of the cases. And the second question was, the further away a data set is, do we still need to update all parameters or do parameter efficient fine tuning? I would say all medical data sets are quite further away in feature space than what these models are trained on, which is natural images. So it's difficult to say which particular, like ham 10,000 is further away as compared to mimic X-ray. But what this paper basically showed us that even for data sets such as medical images that are all quite away from natural images, we still don't need to update the entire model because these models are powerful enough that they do possess the general capabilities to learn from the data. So we just need to update a very small subset of the parameters.
Thank you.
Okay, let's thank Raman again.
Thank you very much.
So the next presentation will be given by Sophie Loy-Zilon. She's actually here from Sorbonne, and her presentation is entitled Detecting Brain Anomalies in Clinical Routine with the Better VAE. So we're looking forward to your talk.
Thank you very much for your introduction. So today I'm going to present you our feasibility study for the detection of brain anomalies in clinical routine data using a beta variational autoencoder and with a special target on white matter hyperintensities. So age-related white matter hyperintensities are lesions in the white matter that appears hyper-intense in FLAIR images that you can see on the left of the slides. So it's clinically interesting to detect these kind of lesions as they are related to vascular risk factors as well as with cognitive decline in elderly patients. And they are quite a very a common lesion in elderly patients. And so in clinical routine, to assess these kind of lesion, they use a FASICA score. So it's a visual rating scale, so a 4-grade rating scale, where 0 corresponds to the absence of lesion and 3 to large, extensive and confluent lesions in the white matter. And so the issue with this kind of visual rating scales is that they suffer from intra and inter subject variabilities, and this can be problematic because it can lead to inconsistencies between studies. And this is why it is clinically relevant to develop an automatic tool that is capable of tackling this kind of task. So unsupervised machine learning and medical imaging have emerged in the last years, and it is very interesting because we don't need to rely on costly and time-consuming manual annotation. And these kind of algorithms are capable of tackling a complex tasks such as anomaly detection. And so unsupervised anomaly detection models learn the distribution of healthy tissues so that when during inference they are confronted with abnormal tissues, with lesion, they are not able to reconstruct it well. And by comparing the reconstructed images that you have on the right with the input image, you can obtain your anomaly map and detect your lesions. And so to perform this kind of task, so we can use generative models. And here for this study, we investigated variational autoencoders, so VAEs. So VAEs have already demonstrated their ability to detect various lesions in brain MRIs and related with diverse pathology. However, the effectiveness of such approach on routine clinical data remains to be demonstrated. And so this is what we wanted to do in this study. It's to assess the potential of these kind of methods for anomaly detection, so on clinical images. So first, to train our VAE, we needed to build a healthy cohort. So first, we pre-trained the first beta VAE using the data from the UK Biobank. So it's a prospective cohort involving more than 500,000 of patients. Neuro images are available for some of the patients. So you have examples on the right, so you can see that the images are quite homogeneous as they were acquired all on the same type of machine. So here it was a Siemens Skyra 3 Tesla, and following a strict acquisition protocol. And so to only select healthy participants, healthy patients, we associated the image with the diagnosis codes, and based on this association, we were able to perform a filtered and to exclude all the images which had a code, so a diagnosis code related to brain issues such as brain lesion or dementia. So by doing this, we end up with a healthy cohort of more than 10,000 FLAIR images. And so using these data, we were able to pre-train our beta VAE that you can see on the right. So we decided to train a beta VAE based on a recent benchmark that was published by Ravi Hassanali, which was comparing different VAEs architectures on a similar task. And so we took the same models. So this VAE was composed of five blocks in the encoder and of a symmetric decoder. So the advantage of the beta VAE is that it performs a disentanglement of features in the latent space by adding a beta weight in front of the regularization loss, so that we can rebalance the reconstruction loss and this regularization loss. So the latent space in our architecture was of size 256, and the beta was equal to 10. So to evaluate it first, this pre-trained model, we use 3 independent test sets. So MSSEG, which is composed of more than 50 patients affected by multiple sclerosis, then 20 patients from ADNI-3, and also 60 patients diagnosis, so with cognitive impairment at the Pitié-Salpêtrière hospitals. And so, in the study, this data set is called a Pitié. So here are the results for our pre-training model. So on the first line, you can see the result for MSSEG. So first, we wanted to test our model on this dataset as it was extensively used in the literature to perform this kind of task. And by doing so, we were able to confirm that our model had similar performance as the one reported already in the literature. So it was the case with a DICE score of 30%. And then we assess the performance of our model on our target tasks, so age-related white matter hyperintensities, using the ADNI-3 and the Pitié datasets. And you can see that we observed similar DICE scores as for MSSEG. So here, to this step, so at this point, we are able to detect age-related white matter hyperintensities using beta VIE, but this we already know. What we want to really assess is this model able to generalize on images such as the one you can see on the right. So these are examples of FLAIR images that was acquired in clinical routine in some Parisian hospitals and that are gathered in a clinical data warehouse that we had access to for this study. And so you can see that in contrast to the UK Biobank, these images are very heterogeneous and were acquired using different machines and no homogenization in the acquisition parameters. So as there are often a drop of performance when you train a model on research dataset and you try to apply it on clinical routine, we decided to fine-tune our model on clinical routine FLAIR, so using the data from the clinical data warehouse of the Parisian hospitals. So we had access to more than 10,000 FLAIR MRIs. So the first things we did is to combine them with the clinical data when it was available. And then we looked, as for the UK Biobank, to the diagnosis code in order to filter again this image to be sure that there were no diagnosis code associated to brain lesions or dementia. And then we also had a look at the radiology report. So we associated the images with all the radiology reports. And we performed an automatically detection on the conclusion to be sure that it refers to a healthy brain for the age, so in the conclusion of the report. And finally, the final test step was a visual inspection of the image and of the conclusion of the report. And so we end up with 674 FLAIR MRIs that was of healthy appearance. So then, using these cohorts, we fine-tune our model by retraining all the layers of our beta VIE. And to evaluate the performance of our fine-tuned model, we built so an independent clinical test set based on the same cohort. And this time we were looking in the conclusion of the radiology report to mention of FASICA's scores. And so we had 204 images, FLAIR images, for which we had in the conclusion reports, in the conclusion of the radiology report, the associated FASICA score. And so here on the right, you can see, on the left, FASICA's 1 images, FASICA's 2, and FASICA's 3. Now comes the results of our fine-tuned model. So we didn't have access to any manual segmentation related to these images, but we had access to the FASICA score. So what we did is to examine the relationship between the FASICA score and the amount of lesional voxels that was automatically segmented by our model. And so this is what highlights the box plots on the right. And so the differences in volume between the three groups were assessed using first a one-way ANOVA. So it was found to be statistically significant, and then we further investigated statistical tests by performing a 2K post-hoc test, and so this time to assess the statistical differences between each group, so FASICAS 1 versus 2, 2 versus 3, and 1 versus 3, and it was again statistically significant. So then what we wanted to assess is the robustness of such model to image quality, because as it was presented before, we have various image quality in clinical routine. And so on the right, we just displayed a box plot so of, once again, the lesions of volumes that was automatically segmented by our model per FASICAS score and per quality MRI. So we did not perform any statistical test because of some very sample size in some of the categories, but what we can visually see is that the order in volumes across FASICAS classes is preserved for the different quality levels, which gives us a first insight of the good behavior of our model. So here are just a few examples with so purple pixels highlighted, so the lesion that was detected automatically by our model. And so to conclude, so we perform a feasibility study to assess the VIE to detect age-related white matter hyperintensities on clinical routine MRIs. So we found promising results with a correlation between the FASICAS score and the volume of a lesion detected by our model. So we have promising results at a group level, but there is still room for improvement at the individual level, and we will need probably to perform further validation with manual segmentation masks to fully assess the effectiveness of such model. So thank you very much for the attention.
Yeah, thank you very much for this very great talk. Do we have questions from the audience? Can you also please remember to limit yourself to one question if you have the mic?
Hello, thank you for the talk. Just I was wondering, and maybe I missed it during the presentation. You said that the thing of beta variation autoencoders is the fact that they disentangle the latent space. But do you make use of this property like actively, or maybe I missed?
We decided to use the beta VIE, so based on the benchmark that was performed in the lab, where several architectures of variational autoencoder were compared. And so the advantage of these architectures compared to classical VIEs is the add of these beta weights in front of the regularization loss to better balance both losses.
Okay. Thank you very much.
Yeah. So I wanted to know on the site, for example, ADNI site, on the clinical site, how many lesions, what is the volumes that you detect on the healthy images?
So for ADNI, we only had we only had 20 FLAIR MRIs that were manually segmented, and so it was a mix of cognitively normal patients, but that were affected by white matter hyperintensity, mainly due to age. After the exact amount of volume, I don't have it in mind. Sorry.
Hello.
Final one.
I will have a question. Thank you very much for your talk. It's very impressive, the number of images that are included in the study. You show a clinical validation of the algorithm. Do you have any result showing the analytical validation of the method, showing, for instance, segmentation die score? So something which is against annotation.
Sorry, so if we have a quantitative assessment?
So you have a clinical validation of the
Yes.
method against a clinical score. Do you have also an analytical validation of the method?
No, so we are using data from the clinical data warehouse of the Parisian hospitals, and to date it's very difficult to obtain manual segmentation on these data, we only have restricted access to these data, so we didn't have any manual segmentation associated to these images.
Thank you.
All right. If there are further questions, you can also ask them at the poster. But let's thank Sophie again. And
So our third talk in this morning session is by Katharina Höbel from the Dana-Farber Cancer Institute on Beyond Structured Attributes.
Yeah, thank you very much for the introduction. I'm very happy to be part of the German session this morning. I'm a postdoc at Dana-Farber and HMS. And I'm happy to talk about our work on looking beyond the structured attributes as we assess and characterize performance gaps for chest X-ray classifiers, and this is work that I did in collaboration with Jessica Fernando and Bill Lauder at Dana-Farber. So the fact that chest X-ray models do not generalize should be nothing new to everyone here. And collectively, as a field, we've done a lot of work really looking into what are the reasons for these performance degradations that we see under domain shift. And some of the reasons are covariate and concept shifts, the propensity of deep learning models to latch onto shortcuts and learn spurious correlations. And then last but not least, there's a lot of effort in characterizing and looking at differences in the distributions of patient demographics as reasons for performance gaps, particularly in the context of fairness. And what all of these things have in common is that they're really looking at structured attributes, that is labels or categories that we can characterize our images into. So we can say an image belongs to one or another group. And group membership or these structured attributes can explain some of the performance gaps, but large proportions still remain unexplained. And this is what we're trying to solve, or what we're trying to not solve, but make a step towards maybe looking into what are these unexplained aspects of performance gaps. So one of the reasons why a lot of focus is actually on structured attributes is the way we define or look at performance gaps. So typically we have a model A that was trained on data from data source A, and then we assess the performance of that model on data from different data set sources. And so here the model itself is at the center. And so this is what we call the model-centric performance gap. And this is the typical setup that you see in these performance gap analysis studies. And this is a great setup to study the effect of data set shifts on model performance, particular aspects of differences in structured attributes between groups. The way we, in our study, define the performance gap is the dataset-centric performance gap, which is a somewhat underutilized perspective on performance gaps. Well, we have a model A, again, trained on data source A, but in addition to that, we also have our model B that was trained on a different dataset source. And then we compare the performance of these two models on the same data. And that shifts the focus towards more towards the training data set instead of the data sets that we evaluate our models on. And it really allows us a direct comparison of models on the same data points. And so in our work, we first needed a couple of models to study that. And we call these models the pathology prediction models, or PPMs. We chose the two most popular chest X-ray data set, CheckSpurt and MIMIC. And then split our data set on a patient level. And you can already see that these numbers don't add up to 100% of the labeled data. We kept 20% of the data separated for additional experiments that I detail later. We trained our models to predict the presence or absence of 12 typical pathologies on these images. And then we did use some structured attributes in our assessments. These were race, patient sex, age, and the radiographic view. And for reproducibility purposes, we use the Torch X-ray Vision library to train our models. But honestly, this is nothing special here. This is your typical run-of-the-mill chest X-ray classifier. And so here are these dataset-centric performance gaps. So every single bar here represents the difference in performance of the two models trained on different data sets, evaluated on one data set. So the orange bars are the differences in the performance of the two models on the MIMIC data set. The blue bars are the differences on the Checkspert data set. And the arrow bars indicate variability across 3 different runs with different random seeds. And you can already see, sort of like on first look, that the performance differences vary across the pathologies. This is in part due to label availability in the training data set, but we cannot explain all the variability by the amount of training data that we have available. And so because of these differences, there is some sort of what we call a pathology context dependency. And so we limited our evaluation to the context of 3 different pathologies and look at these pathologies more closely. And the pathologies that we chose were pneumonia, pneumothorax, and pleural effusion. When we started looking at image level predictive tendency differences, we first plotted the predictions of the 2 different models, so the Checkspert trained model on the x-axis and the MIMIC trained model on the y-axis, for pneumothorax predictions. So really comparing the predictions of the 2 models on the same data points and looking at the distributions here. And this looks fairly random, but we were wondering whether there is a difference in the images that are located above or below the gray dashed lines. So in other words, are the images for which the points of like data represented in the orange shaded area differences systematically different from the images that fall below that gray dashed line and are in the blue shaded area. And to quantitatively describe that, we introduce a new metric or concept, which we call the predictive tendency. And in essence, what the predictive tendency measures is the difference in the predictions between the 2 models on the same data point, in particular the directionality, so which prediction is higher. And these are not the raw predictions, these are actually, we rank the predictions for every single model to account for calibration differences. And so the blue shaded area are in essence the images for which the prediction of the Checkspert model is higher than the MIMIC model, and vice versa for the images that are in this orange shaded area. And so our question, or our quest, was to figure out whether this predictive tendency is as random as it may appear on a first look, or whether it is influenced by factors that are encoded in the images. And what we usually do in these settings, we look at structured attributes as sort of like a first step, because it could really be that like group memberships are explaining a lot of the trends that we see here. And so here you can see the distribution of the predictive tendencies for images categorized by the radiographic view. We do that analysis separately for MIMIC and Checkspert to account for general differences between data sets. And this is only for images that have a positive pneumothorax label. So the presence or absence of the pathology shouldn't influence this assessment here. And I think just visually, we can appreciate that there are differences in the distributions of the predictive tendencies for the different views, with the anterior-posterior view generally having lower predictive tendencies than images with a lateral view. And these differences in the distributions are statistically significant. However, as we can see in the effect size, what you see in the gray box, is that the group membership, so the radiographic view, doesn't explain a lot of the variability that we see in the predictive tendencies, but it does explain some of it. Here we have the same plot for images with a positive pleural effusion label. Interestingly, you can see that for pleural effusion images, the predictive tendency of anterior-posterior images is associated with a higher predictive tendency. Overall, we found the strongest association of the predictive tendency with the radiographic view. For images with pleural effusion, we found a weak association with patient sex, but we didn't find an association for images with pneumothorax or pneumonia. We found no association with patient race and age. And we also found no association with first-level image intensity distributions. And so the structured attributes can maybe explain some of the variability in a predictive tendency, but really only a small sliver of it. It's also not the image intensity distribution itself. So you're wondering whether it is high-level image statistics that determines whether one model outputs a higher prediction than the other. And this is where we trained our comparative data set models, or CDMs. Our hypothesis here was that if the X-rays indeed contain information that determines the predictive tendency, so if it is a systematic difference, then this relationship can be learned by a deep learning model. And this is here where we use the 20% of the data set that we haven't touched yet. And so we do the data set curation with this 20%. We split that into images that have our target pathology, let's say pneumothorax present or absent or don't have a label at all. And we only keep the images that actually contain the pathology so that the presence or absence of a pathology does not influence our model performance. As a training label, we use a binarized version of the predictive tendency, S prime, where we binarize at a median in the training data set, which is roughly equal to 0. So we can think of the images with an S prime of 0 as the images for which the PPM, the mimic trained PPM outputs a higher prediction than the check-spurt trained PPM, and vice versa for images with an S prime of 1. We use this data to train our models, our CDMs, and then obtain an inferred predictive tendency through these models. And we do this process separately for check-spurt and mimic, and also separately for our 3 target pathologies, so that we don't accidentally introduce any confounders into the model. So the question now is, are these comparative data set models able to infer the predictive tendency? And the quick answer is yes, they are. So here are the AURCs for images with pneumothorax for the pneumothorax CDMs. And as you can see, the AURCs are well above chance level. Same for images with pneumonia and images with pleural effusion. So we were successfully able to train these models. I'm going to speed up a bit. We also see some cross-data set performance. So models trained on check-spurt were able to predict to infer the predictive tendency for images from the mimic data set, but we didn't find a generalization across disease contexts. And just a quick teaser here, if you want to know more about this, come to our poster and talk with us about this. We wanted to know whether we can pinpoint what the model is learning to a certain frequency range, to like high or low frequency content. The quick teaser here is it doesn't. There appears to be some redundancy, and I think it was interesting to us that images that visually really don't contain a lot of information, the models were still able to maintain, the CDMs were still able to maintain their performance. So that was interesting. So we introduced a data-centric perspective to examine performance gaps between deep learning models, and we introduced this concept of the predictive tendency to quantitatively evaluate data-set-centric performance gaps that are pathology-specific and depend on high-level image statistics. And if this, had any influence on how we apply models potentially in the clinic, the question is the same, in what patient and image setting is one model always the right model? The answer is probably no. So we can think about smart ensembling strategies that are dependent on a specific patient and image context. Okay, thank you.
Thank you, Katharina. So we have the chance for some questions up there.
Should I start? Hi. Thank you for the talk. I think this is good to think about this evaluation procedure. And I was thinking, do you have any ideas of maybe using this as a basis to unbias certain models, in a second step?
Was it unbiased?
So, okay, so you have 2 models. Mm-hmm. They have great performance on some stuff. but you can measure their discrepancies in some part of your data space, right?
Yes.
So you can think this is evaluation, this is interesting, but how to use that to make better models.
To make, yeah, either to make better models or, as I just mentioned, thinking about how can we choose the best model for a specific setting. So I think that's how we thought about it. It's a good thought to essentially go backwards. We haven't really thought about that. It's a good question. Yeah.
Thank you.
Okay, thank you. The second question up here. You're just carrying the microphone. Okay. Veronica, please.
Thank you. Thank you so much for your nice presentation. So I was wondering, somewhere in the beginning you had the gaps in the AUC, and I think they're absolute gaps, if I understand. Would it make sense to look at sort of a relative gap with respect to like the overall how easy or difficult the task is? Because I think pneumothorax has overall like much higher AUCs typically than pneumonia, for example.
Yeah, so I guess like there are two things that play a role here. There's the question of like how easy or simple is a prediction task, which I would also pose the question of like, what is the view that we give to that model? Because we expect the model to perform the same on like APPA and lateral images, but like as a physician, I wouldn't use certain views to diagnose something. So it's a very nuanced question. And then I guess the second question, and we have that plot in the paper, so I would encourage you to look at that, where we look at the sort of like the label availability, the amount of training data of the certain labels that we have available. That certainly has an influence on the performance gaps as well. So it's a twofold question, and we weren't quite able to disentangle that, and so that was certainly part of like how we chose the three pathologies that we looked at. But yeah, those plots are not normalized for any of these confounders.
Okay, thanks a lot. I'll join for the poster also.
Okay, thanks.
Any further discussion? I think we have to defer to the poster. Let's thank Katharina again.
Thank you.
And next up, we have a presentation of Amit Kamath. He's from the University of Bern in Switzerland and will be presenting a comparison of the performance of radiation oncologists versus a deep learning-based dose predictor. So the floor is yours. And
Great, thank you. Looks like my fonts are not the best, so sorry about that. My name is Amit. I come from the University of Bern, and I'll be speaking the next 13 minutes or so. I set up my timer, so I'm hopefully on time, on comparing the performance of radiation oncologists with a deep learning model for a dosimetric evaluation of segmentations for radiotherapy. If I bored you too much in the next 13 minutes or so, all the slides will have the QR code of our full paper, so please scan it, and then we can talk later in the poster session as well. Okay, so the three broad takeaways from my talk are going to be these three. So essentially, we believe radiation oncologists are going to transition from the task of manually segmenting to evaluating auto-segmentations, and this opens new clinical challenges. The second takeaway is that early discussions, I think, with clinicians are essential, and I'll explain how we found that out in the process of working this project to build the right kind of tools that they can use in their clinics directly. The third takeaway is that beyond segmentation itself, there's a lot of applications of deep learning models in the broader radiotherapy workflow, including for quality assurance of these models. So very briefly, what is radiotherapy? The idea is there are, let's say in anatomies like the human brain, there are tumors, which we denote here in red, and there are other healthy brain tissues, also called organs at risk. Ideally, the tumor gets the full prescribed radiation dosage, and the organs at risk, which are here, will get a low, ideally zero dose, right? But in practice, because of the constraints of physics with the scanner and so on, The organizations get a small dose, which hopefully is safe, whereas we want to give the tumor the prescribed high dose, right? So this whole trade-off between giving the prescribed dose to the tumor while minimizing the dose as much as possible to the organs at risk, this is the whole idea behind radiotherapy planning. Now, in the clinic, there are many steps in the workflow, starting from decision to get treated to follow-up care. But the three sections here in between, imaging, treatment planning, and the whole quality assurance of this step, these three are the most ripe domains for involvement of AI and automation. And so if we dive a little deeper into this workflow, what currently happens in the clinics is, of course, you take images. These are MR images to actually identify the locations of tumors and organs at risk, and CT for doing the planning. And then there's this whole contouring step, and then the whole treatment planning stage here. So if you notice at the bottom here, these are the durations of time that's taken currently on average in the clinic to do this. And you also notice that there are various clinical players or actors who do this as well. So one of the reasons for why this takes so long is because there are so many people doing this in the clinics, and they have to coordinate and schedule with each other and so on. So you can see this takes roughly about 2 weeks, which is quite a long time. And thereby, it's currently manual in most clinics as well, the whole segmentation step. So there's a lot of scope now for involvement of deep learning models and essentially automation. Of course, there was a whole session on segmentation yesterday, but you're probably familiar with the challenges with segmentation. This is time-consuming, takes highly trained specialists to do this. And if you ask different specialists, they'll give you quite different answers. Here's an example of hippocampus being segmented quite differently by two different experts. Beyond this, though, the question I'd like to ask you all is, can we measure segmentation quality purely using geometric measures like Dice and Hausdorff? Leading question. We believe the answer is probably not. And we've actually shown in the past that geometric metrics, purely Dice, for example, do not correlate very well with radiotherapy outcomes. So depending on where these, for example, in the image you see here, the outliers, one of our experiments earlier was to move these outliers in different relative locations to the tumor itself, which you see in red. And then depending on the location and the size of these outliers, potentially the geometric scores will be the same, but the impact from a radiotherapy perspective can be very, very different. So there's quite a complex relationship between these shapes and their locations with the outcome of the plan that's made. So the community, of course, is heading more towards auto-segmentation or using all of these fancy deep learning models that we're all building. And there's quite a lot of acceptance from the community, it seems like, to be able to do this. However, the question then is, what happens after, let's say we deploy a model like this? In case there are problems in the behavior of these models, we have to invest more time in fact, quality testing and assuring that these results are reasonably good, right? So the first takeaway I come to this now is that reviewing of these segmentations is now sort of going to become the more predominant task of radiation oncologists now that they start using these models. But if the time they take to review is very close to the time they actually need to draw this, what's the whole point of us building all of these models, right? So that's kind of the challenge here. So with this context, and I think I'm halfway into my talk, here's the study design of our work for this particular paper, right? So what we do is we have a bunch of reference tumor segmentations in green here, and then one of our expert dosimetrists, he made a bunch of small changes which you see in red in the second panel here, on the tumor segmentations themselves, right? So these are manually made, and then there are 54 of these pairs. So these take quite a lot of time to actually replan and perform the whole clinical testing. And so what we then do after that is we go through the typical clinical treatment planning workflow to generate these dose plans for each of these pairs of segmentations and their changes. Then what we do is we classify these changes with respect to the reference tumor as being dosimetrically worse, no change, or better. So these, I'll explain a little more later on how we do this. But we have these three categories based on the changes that have been made, right? Now, with this kind of data set prepared, what we then do is we go on the one side to human expert radio-oncologists and ask them, can you classify, just by looking at these segmentations and changes, can you classify if you think this is going to be a worse or a better segmentation? And we train a deep learning dose prediction model to try to automate this whole process of review as well. The metrics, of course, are standard classification metrics, also with compute time, just to measure this too. Now, this deep learning dose predictor model that I mentioned earlier, this is a standard, it's called the cascaded 3D UNet. So what it does is, so this is really done after the step of what your segmentation model gives you. So your segmentation models give you binary masks of all the structures that are interesting. And then this model takes them as the input along with the CT, and then it generates what the dose could be that you could deliver using the current machines in the hospital. If you have more questions about the details of how we train this, maybe we talk later or in the questions section. But I'll move on to how we made this classification of what is better and what is worse. This is still, from a clinical perspective, sort of fuzzy sort of a situation. But we came up along with our clinical collaborators with this little algorithm. Essentially, broadly, the idea is if the dose to each of the organs at risk, if it increases by more than 10% after the change has been made to the tumor segmentation, and if this happens for a fixed set of organs at risk, either 1 or 3, then we say the situation is worse, and so you have to keep that in mind, right? If the dose improves or is less than 90% of the original reference dose, then we say the situation is better. So that's broadly how we categorize this. And so this is really, the second takeaway here is discussing early with the clinicians really is important to come up with the right set of metrics, the right set of measures that really are meaningful to them as well as to us. We love things that are easy equations that we can put together on a slide, but then clinically it's a lot more complicated in general. Also, just to clarify, we used the same algorithm for both the clinical model as the current clinical planning system as well as our deep learning model. Okay, so now switching over to what we showed the 3 expert radiation oncologists. So we used 3D Slicer, so thank you for those of you who worked on developing such open software. To show all the 3 slice planes, as well as a 3D representation of the segmentations on the T1 contrast images. And they could actually interact with this and then get a sense of both the original segmentation in green as well as the changes in red here. Here's another example of how these changes look. So these are, you could say, reasonably large changes. The red parts here are the modifications that have been introduced. Okay, so coming into the results now. So what we see with this classification task between radiation oncologists and our dose prediction model is that the model performs better mostly. Particularly in the case of if you compare radiation oncologist number 3 and our model, you see that the recall numbers are the same, but the radiation oncologist on average takes more than twice the amount of time that our model takes. Also, there's quite a lot of variation in the time they take based on the complexity of the geometry of the case, whereas the model is always geometry agnostic in that sense. Here are the confusion charts as well, confusion matrices. And what you notice here roughly is that most of the humans are really biased towards no change, meaning that even if there are real changes, as measured by dice scores, for example, in the segmentations. The radiation oncologists tend to think that this doesn't matter from a dose perspective, which is really interesting because what does it mean for us to say my dice score is 0.92 versus 0.85, right? The radiation oncologists don't seem to care very much about it. So really the takeaway otherwise here is that the dose prediction model performs reasonably well with changes that happen to the segmentations. What we show here in the previous paper really is that the dice doesn't correlate exactly with the change in the dose, whereas the dose prediction model has a strong correlation. So the third takeaway is really that these deep learning models can help in assessing things like the quality of segmentations and even beyond in the workflow broadly in radiotherapy. The task for us next is how do we build a useful clinical tool and not just end up as just another middle paper this year. That's something we are hoping to work on next. Here are some situations where the model performed on the top. The model performed well, but the experts did not. And at the bottom, situations where the experts got it right, but the model did not. So there are a lot of situations where I think there's scope for improvement. At the end, finally, we want to have a more streamlined quality assurance workflow for radiotherapy. This is there was a talk yesterday about co-pilots in the whole workflow, so that's kind of where we want to end up to be more consistent, time efficient, and accessible. That's it. So I'll leave you with the 3 takeaway slides, takeaway messages, and here are my collaborators. Thank you very much for your attention.
Thanks a lot for the nice presentation. Do we have questions from the audience? Okay.
Hi, thanks for your presentation. So if I understood your talk correctly, what you're doing is that you build a model that will take, let's say, a segmentation mask and potentially another part of the mask and assess whether this other part of the mask will degrade or not the dose planning. Mm-hmm. But then my question is, like during the actual, like in the clinics, when you want to use this tool, how will you have like these other bits of the mask?
Sorry, I couldn't hear the last part. How would you?
So, like, how do you create like the red part of the masks that you design and says like, oh, with this change, will the dose calculation be better or not?
Aha, okay. So if I understand right, your question is, in real clinical practice, how would you create this additional change to the segmentation to evaluate? Absolutely. So the way we envision, so this is clearly just a study to find out if humans and models can do reasonably well in these scenarios. The way we think in clinical practice this would work is, let's say an auto-segmentation model gives you a particular segmentation, and then the clinician will say, okay, what if I make this little change here? How would that impact my outcomes? So that is the change that in the whole review stage, we think that is a change that they'll make, and then they can use these systems to say, okay, this change really made things better or worse, and thereby help them make that decision of, is that change worth doing or not? Did that answer the question? Thanks, yes.
Hi, thank you for your talk. You showed that the changes in dice score did not agree well with the plan quality changes. Do you have a sense? We know that human quality perception for brain tumor segmentation does not agree with the dice score, but it agrees better with things like the Hausdorff distance or the surface dice. Do you have a sense of how your plan quality changes agree with changes in Hausdorff distance or surface dice?
Yes, so thank you for the question. The broad idea, I suppose, is surface dice or Hausdorff. Are there other geometric measures potentially that are better correlated? In our experience, Hausdorff measures, Hausdorff distances are better because they are much more harder to get around in some sense. So if you have outliers that are really far away, it penalizes you very much. So Hausdorff distances are certainly better. However, I think there's the message we want to show is that we have to think beyond geometric metrics. There's what happens after your segmentation model does its thing. I think incorporating that knowledge into your quality assurance of your segmentation model, that's really the message we want to share. But you're right, there are other metrics potentially that could be better than DICE. I mean, DICE has this whole volume problem and so on, so which is where surface DICE could help, for example, yes. Yeah.
All right, let's thank the speaker again, and we move to our final talk.
All right, now we come to the final presentation of the morning session already. The presentation is by Lulin Shi from Hong Kong University, and she will introduce her model, thick V-stain.
Okay, so thank you so much for the introduction. Hello everyone, this is Ivy from Hong Kong University of Science and Technology. So I'm presenting on behalf with my team. So welcoming you to the topic of thick V-stain and process thick tissue virtual staining for rapid intraoperative histopathology. So perhaps let me begin with a question. So I believe many of you must have lots of experience perhaps working with H&E images, but how many of you actually familiar with how the upstream process and how the H&E data is prepared? Could you quickly show with your hands if you do? Great, so great for those of you actually know, and no worries if you don't. So I will try to explain a slightly more detail to explain you why we have the motivation for this work. So once the tissue is excised from the patient body, in the conventional histopathology, it actually has to go through a series of sample preparation steps. From the tissue will have to go from the tissue processor, embedding it, sectioning it, then you get the thin slice, followed with the H&E staining, microscope scanning, then you get the H&E data. Everyone is familiar with it because it is the gold standard, highly accurate for diagnosis. But the bad side of it is obviously is tedious sample preparation step, and it is also time consuming. It could be taking from 3 to 5 days from the tissue all the way to the H&E data. So there's indeed a much faster alternative frozen session, taking 30 minutes, often used in the intraoperative margin assessment. But the bad side of it with a trade-off of accuracy due to its inherent artifact. So therefore, in this work, we are trying to propose a method of thick V-stain. So taking in the label-free images, in our case, is the autofluorescent image, AF image developed in our lab. So we take in the image, doing the image translation step to H&E-like images. So what we are envisioning is, once we get the tissue, we directly image the tissue surface, then we virtual stain it, so we can generate the H&E images in less than 5 minutes. So it sounds really amazing, but for sure there are several research challenges. So one of the first challenges we encounter is the low image quality of our input images, AF image. So because the AF image is actually a thick tissue image, so multiple layer information will be captured at the same time in one 2D image. So as you can also imagine, the imaging depth of our thick tissue image is much longer than the thin section that you normally see on the H&E image. It's just 2 to 7 micron, whereas our imaging depth is tens of micron. So the information of our AF image is actually more complex without any physical sectioning. So especially when the imaging depth is much longer than the depth of field of the optical system. So there will have much more blurriness in the thick tissue, as you can also see on the right-hand side. It may not be as good as the image quality that you normally see in the H&E. So you can also see it is more blurry on the AF thick tissue than the AF thin section. So the second challenge is also about the morphological difference between the fake tissue and the fin section. It is not possible to obtain spatially aligned data of the unstained fake tissue image with the stained H&E image because it is normally carried on fin section. So in order to address the challenges, we harness the ability of multi-scale model to for a better understanding of those complex data. So at the same time, we're also using unsupervised method to address the issue that we cannot get aligned data. Here, we're trying to use different scale to capture different level of histological pattern, so for a better multi-level of representation. For our current unsupervised method, CycleGAN is normally used as a basic architecture. But then one of the issue is when we are normally current many methods are focusing on fin section, but when we are moving on fixed section, you can see in the middle image, the model output, CycleGAN actually cannot distinguish the difference between the background as well as the tissue content. This is because the cycle consistency loss actually cannot guarantee the model output will be transformed correctly when compared with the ground truth. Even if the model output is transformed incorrectly, because of the loss, the reconstruction can still recover perfectly. So you can also see in the image. So therefore, we actually decided to take away the cycle consistency loss, and also to avoid the increase of the computational resources, we choose the one-side method instead of two-side as a CycleGAN. In terms of the loss function, we do use the identity loss to preserve the original structure, as well as the original GAN adversary loss. Here we compare the result between the single-scale and multi-scale model. As you can see first on the fin section, actually the single-scale can work pretty well. And the difference between multi-scale and single-scale is not too much different. But then the focus, when we are focusing on the fake tissue, the difference is more obvious qualitatively. As you can also see that the single-scale method is not able to capture the fibrosis information, and also the FID score quantitative matrix is also far from satisfactory. So here highlighted that the multi-scale model is actually crucial in handling complicated data, and also one more point to notice that the FID and the quantitative matrix on the fake tissue is still much lower or not as good as the fin section, so indicating that the virtual staining task on the fake tissue is actually difficult to achieve comparable result on the fin slice data. This is still one of the challenges. So quickly going through about how we prepare our data. So we acquire our image set with the AF images in our lab ourselves, as well as getting the H&E staining data for the fin section. We get it from 14 patients with lung adenocarcinoma, using 7 patients' data for training, 7 patient data for testing, with test data set around 31317 image pages with 256 × 256 size. So here's the result of our fixed sample data. So we compare our result with the adjacent H&E references, because fake tissue we cannot get the exact ground truth for the H&E image. But at the same time, we also choose to compare with other commonly used unsupervised method, the UTOM, the CUT, and also CycleGAN. Here you can see qualitatively the fake V-stain indeed do have a superior performance in capturing the fibrosis information, the solid adenocarcinoma pattern, as well as differentiating the tumor and normal region. We also try to demonstrate our fake V-stain on the fin sample to show its generalizability on the fin section. So quantitatively, because we cannot get the exact ground truth for the fake tissue, so the common metrics say the SSIM, PSNR, and MSE cannot be used on thick tissue, but then we can use it in thin tissue. So, so therefore, we are trying to use some node reference metrics, for example, FID and KID to quantify the evaluation. At the same time, we also try to use TMSE to measure how well the tumor can be recognized on our virtual HNE images. So tumor TMSE. So I can explain a little bit more about that. As we try to use a tumor detection model, classification model to evaluate with our virtual HNE images, comparing it with the real stained image, and we get the mean square error comparing with the two. So to quickly wrap up, so here we propose the fake V-stain rapid pathology method, demonstrated the virtual histological staining on complex unprocessed thick tissue using a multi-scale generator. So by doing that, we enable a rapid alternative workflow to generate the histopathology image with label-free microscopy. At the same time, we also try to show that this virtual staining task is also compatible with more downstream tasks. For example, in this case, we try to integrate it with the tumor detection model. But in theory, we also believe that it do have great potential to integrate with more downstream tasks. For example, report generation or any other thing. Yeah, so I'm happy to discuss with any collaboration opportunity. So that will be the end of my presentation. Thank you very much. I'm open with any questions.
Yeah, thank you for the presentation. We already have a question up here.
Hello. Oh, thank you for the impressive talk. I just have one question about the downstream task. I was wondering if you ever tried some other more clinically relevant downstream tasks, like predicting the diagnosis. Hello, can you hear me?
Predicting the diagnosis.
Diagnostics or prognosis, or even the patient outcome. Yeah.
Understood. Yeah, I think that's is really interesting area that we really like to explore more. So we only try to initially test with diagnostic different lung cancer subtype, for example, adenocarcinoma or is a squamous cell carcinoma. But for the prognosis area, we haven't touched on it.
Okay, I don't see any more urgent. There's another question here on the left.
Yeah, thank you for the great presentation. I was wondering, I'm not familiar with AF microscopy images, but could you try to also see if you gained something by first translating and then doing the tumor detection versus trying to do it directly in the AF images? Would that be possible?
Understood. Yeah, it's definitely possible to directly do the classification on the AF images. But one of the reasons why we would like to first translate to virtual stain images is because we have to translate it into something the pathologist can understand and interpret. So it's a credibility. And also second is, I believe, if we are translating to virtual HNE, then we can also leverage the efforts in the community working with the HNE image. So it may be also something that is synergistic.
Okay, thanks a lot. Okay, final question, very brief, please.
All right, very, very brief. So thanks for the talk. I was just wondering, so you're predicting here the H&E image, and I was curious if you've considered predicting other special stains like Mason trichrome or PAS or Sirius red and all those things, because the details you need to see on those images are less fine, so perhaps your thick slices might be more appropriate for predicting special stains like this.
Yeah, we actually, because the AF images itself is very good in visualizing some fibrous detail, for example, the collagen and elastin. So indeed, we have also spent some effort to try to virtual stain with Mason trichrome EVG as well. PAS, we have tried a little bit.
Okay, so let's thank her for the presentation.
Thank you.
And also thank you for participating in this lively discussion. I will hand over the microphone.
Very much. So now we're moving on to the sponsor session with
slideshow.
Okay, so for this sponsor session, we have 3 sponsors, and we're going to start with Siemens Healthineers.
I have a slideshow, no worries. Sorry? Siemens. Yeah, with video. Yeah, and no worries. The presenter show. The presenter show. Okay, it's good. So thank you, everyone. First, I hope you are all doing well. I'd like to thank the conference chair for the organization and for giving me the opportunity to be in front of you today. So the talk is called Artificial Intelligence in Healthcare and Why It Matters. So my name is Guillaume Chabin, currently a senior staff scientist at Siemens Healthineers. My research interests include segmentations of organ risks and targets for cancer treatment planning, as well as detections and segmentations of focal liver lesions for screening and treatment response assessment. So Siemens has a history of more than 100 years in healthcare, and our main reason for success and longevity is innovation, right? And if we look at MRI as an example, you can see here on the left side one of the first MRI of the human brain that has been acquired in 1980. And on the right side, a rendering of a tractography that can be acquired on today's 7 Tesla's machine. So the tractography will actually represent the neural pathways of a real brain of any individual. So when I see those renderings, I'm always impressed by the beauty of the images, but also how much information we can capture through non-invasive images. And today's our development of deep learning are at the center of our innovation strategy. In the coming years, the healthcare system will face major challenges in the global access to care. On the one side, you will have the population growing rapidly. We estimate that by 2050, more than 9.7 billion people will need access to care on the planet. And at the same time, there is a global shortage of medical staff, whereas an estimated shortfall of 18 million healthcare workers by 2030. However, with the computational power and the internet connectivity growing exponentially, the advance of AI are opening quite rapidly. And we believe that deep learning is a key part of the solution. And the level of automation through healthcare will continue to rise, supporting the healthcare worker, but ultimately benefiting the patients and the healthy individuals. So I'm part of a central hub for research and development in AI for Siemens Healthineers. We have a global team of 200 colleagues, including scientists, engineers, but as well annotators and clinicians. We have our headquarters in Princeton in the US, but also offices in Germany, Romania, China, India, and I'm currently also opening a team in Paris. Our mission is to advance technology in healthcare by pushing the state of the art, as well as translating our innovations into the products that are used in clinical practice. To achieve this goal, our team of over 100 scientists and 60 clinical readers are closely collaborating with healthcare providers, universities, public agencies, and key opinion leaders. We leverage a dedicated supercomputer of 340 petaflops, sitting on top of a data lake with more than 2 billion records, and currently we run more than 1,400 AI experiments per day. Our research impacts the entire portfolio of Siemens, Celsius, and Varian across every stage of the patient journey, including screening, diagnostic, and therapy. It's integrating into imaging equipment, treatment machines, lab diagnostics, and post-treatment softwares, spanning a wide range of clinical specialties. But more importantly, it's fighting the most threatening disease, such as cancer, stroke, and cardiovascular conditions. So in the field of diagnostics in oncology, AI has many applications. Our team has developed a large portfolio of algorithms, including early detections and risk stratifications from lab tests and chest x-rays, screening algorithms for breast cancer on DBT images and lung cancer screenings on CT, lesion characterization for prostate cancer on MRI, and cardiotoxicity assessment on cardiac images. But our achievement extends diagnosis, and I'll share now two samples that one of them were already touched in this session that are gaining a pretty important tractions in the clinical community. So the first one is auto-contouring for radiation therapy. So as explained earlier, the radiation therapy involves a lot of segmentation tasks. One is the segmentation of healthy critical structures that are near the tumor, and the second is the segmentation of target structures to be irradiated. So the contours are required to control the radiation exposure, avoid damage to organ at risks, while making sure that the prescribed dose are delivered to the targets. So currently many sites are doing this task manually or with semi-automatic tools, which, as you can imagine, is quite tedious and time-consuming. So our automated auto-contouring algorithms currently supports more than 150 structures for segmentations, target structures in the pelvic, breast, head and neck cancers, and multiple clinical studies have shown that more than 95% of our contouring results are clinically usable with no or just minor edits, leading to drastic reductions in the contouring time. The second example, I believe you will be a bit less familiar with it. So it involves the use of deep learning in MRI reconstructions. So the physics of MRI introduce an inherent trade-off between the image quality, the acquisition time, and the magnetic field strength. So while deep learning cannot bring more Tesla on the machine, it has proven extremely powerful in the reconstructions and the processing pipelines. So it allows higher quality, producing images with less noise and with higher resolution, but as well with faster acquisitions with up to 88% regression in the acquisition time, bringing a series acquired in 2.5 minutes under less than 20 seconds. So this is a major progress for the radiologist, but it's also a really nice outcome for the patient experience. And if you remember the first MRI I showed you acquired in 1980, just as a comparison, it took 20 minutes to acquire this first image. All right, to conclude the presentation, I'd like to look at the future. And so in this slide, it's a representation of the famous Moore's law. So in just a few years, our supercomputer will reach exaflop, which is already 100 times more powerful than when I started. So obviously, this jump in the computing power will allow the teams to run AI experiments that are currently limited by our infrastructure. But the blue curve is also quite interesting. So it shows the progress of the computing power at the point of care. So that means in the coming years, we will soon match what was yesterday's supercomputer. So we believe that this achievement will enable the community to embed very complex models on site, leading to more sophisticated and more predictive products. One example for us is that we recently trained a foundational model using self-supervision on more than 500 million images. So this system can learn a bit of everything from each image modality with and without existing annotation. Parsing through 500 million images for radiologists will take more than 150 years, assuming they will spend 10 seconds per image and without any time break. So these features learned by these foundational networks are then leveraged on downstream tasks such as abnormality assessment, resulting to an increased accuracy, higher robustness, and also a much faster time to train the downstream model. So I'd like to thank the whole team in our company that's working on these topics, pushing AI forward on a day-to-day basis. Also, I'd like to thank our clinical collaborators around the world with whom the projects won't be possible. And thank you for your enthusiasm, your interest, and please check the current openings in the CARI website. But I also encourage you to contact me directly here at the conference, on LinkedIn, or just by email. Thanks for your time, and yeah, I'm ready for your questions.
Thank you. Any questions? It was all crystal clear. Oh yes, one question here, please.
Thanks for your talk. I just have a question concerning your opinion.
Sorry?
About your opinion about the role of the scientific community compared to what you guys are doing, because we will probably not be able to compete in terms of hundreds of years of radiology or radiology support, etc. Even these kind of computational capabilities you guys have. What do you expect from the scientific community to work on in order to be useful to the patients, to the doctors, and to the translational approaches?
I mean, first, I think that this 100 years of experience is not like an isolated journey, right? I mean, clearly MRI is also a great example of, I mean, research happening in industry and scientific community, right? I don't think MRI scanners won't be. And for instance, also in France, right now there is a lot of works done at the CEA, right? Or pushing magnetic field strengths with, of course, industry. But I mean, industry is not really doing a lot with the scientific community. So now, what I would expect, or my opinions on what can bring the scientific community. I mean, honestly, I would say maybe more creativity or opening. So, I mean, you've seen one of the mission of our lab is to translate to products, right? And sometimes on the roadmaps or on timelines, we also have a big pressure on the strategy of Siemens. So we might not have the time to explore all the regions. So I think scientific community can really help exploring areas that we don't. And yeah, I think another aspect in universities, you also have the chance to sit very close to university hospitals. So while an industrial might not be able to work, I mean, industry will be able to work maybe with multiple university hospitals at the same time. So more having a, multiple cohorts, right? You have, I guess, a deeper access to clinicians, and as it was also explained in the radiotherapy talk, really, grasping everything that is clinically required, focusing on what matters for the patients or the users. I think it's something that can be also learn a lot on the scientific side. I'm not sure if I really understood or if I answered your questions completely.
Maybe partially, yeah.
Okay.
I was expecting a bit something more like deep, let's say, but...
All right.
Yeah.
So, I mean, we can have a longer discussion
yes, sure.
next to it.
Thank you.
Maybe one more question. Robin, juste à ta gauche. Merci.
Hi, thank you for your talk. Thank you for your talk. I wanted to ask about from academia, in academic setting, we always wonder the things that we are trying will never reach the clinic, or most of them do not reach the clinic. What is your perspective on in the industry? How many of the things that you try never reach the clinic?
I mean, it's clearly not 100%, and it's all expected. And I think it's a good thing having not everything going through the clinics. There is a lot of work that we also do as explorations or looking at what could be trends. I mean, I think in the few years, the past few years, LLM had a big boom. We also had the segment everything approach that we just want to understand how it can impact in the future. We don't know yet. We don't know if it will be a product, but we're also exploring, right? But then on everything that we do, and also on the academics, you learn from it, right? So like this work on the foundational model at the end, I mean, clearly we won't have, or I don't know, I want to maybe speak for Siemens as a whole, but I personally don't think we will have a foundational model in a product, right? But it can, or in the next few years, but it can also really helping us develop other algorithms that could be helpful, or in a very domain specific for clinical routine.
Thank you. I get from your answer that the zeal is same.
Yeah. I think, and it's a good thing, right? I think I learned more on things that are not going directly to products and where I can iterate things, what's not working, and so on.
I suggest we thank the speaker once again.
Thanks again. Thank you.
And let's call Raphaël Prévost from Infusion, our another gold sponsor which has a booth here on the site. So Raphaël is a head of machine learning and a senior research scientist.
Good morning, everyone. So Infusion is very happy to sponsor this year again the MIDL conference. So I'd like to thank the organizers for the opportunity for us to present our work. So some of you might have already talked to us at the booth or at another conference, but for the others, we're Infusion, so we are an independent R&D company, and our mission is to solve problems related to medical imaging that are most of the time pretty complex. So we're a company founded in Munich, Germany in 2012, and right now we have approximately 50 full-time employees. And just to give you a bit of a concrete idea of the kind of things we're working on, I'll just show you two examples. So for instance, we're here looking at a suite of algorithms that are able to process CT images of the spine. So you just take one CT image and automatically you have a bunch of machine learning models running in the background that detects all the vertebrae, some of the key points, and are able to segment them in a couple of seconds. And these kind of things are used for surgery planning or surgery navigation and are currently integrated in a number of clinical products and are actually used during surgeries. I mentioned some more complex problems, and this is one of them. So now we have much more than one image. So we have here an MR image of the knee. We've segmented it pre-operatively, and this is what you see in the bottom right. This is the mesh, the resulting mesh. And during the procedure, we acquire an ultrasound sweep. So it's a stream, a video stream of 2D images with tracking position. So it's displayed in 3D, and in real time we segment the bone in that case. This is the red line you see, and we can construct a 3D point cloud and register it to the pre-op image. And everything happens during the acquisition in real time in the background. So it puts together a lot of technologies together. And so perhaps the main message is I want to convey is that our company, I think, is pretty unique in the sense that it's a mix. It's hard to define. It's a mix of R&D consulting we do, but we also, to some extent, a software provider and a research lab. And I think this is really important to mix the three things. So it's not like separate divisions, but like our daily work is to combine those three aspects, because it makes everything let's say more ready for clinical use, which is one of the questions that was asked before. And so I want to quickly mention those three aspects. So in terms of R&D consulting, this is what we do basically to earn our money. So people come to us with a specific set of problems that are usually innovative, sometimes with crazy ideas. So we have to start with feasibility studies, but we also conduct the research and development parts, the implementation and integration, all the way to the product certification. And what's important here is that basically it means that the same team is able to take one project really from the beginning and the inception all the way to the actual use in clinical practice. What that also means is that it's the very same code that is done for research purposes and for the final products. And this means that we have to put a lot of emphasis on our code. Being able to do something like this, like to do research on a project like this, but also making it happen on a real system is incredibly difficult. But basically what we decided very early on is that we invest a lot of efforts and resources in the modularity of our framework, because then you can use it for research, and it's product-grade code that our customers can directly integrate and try in practice. What that means in practice is that we have a set of libraries, common libraries, that the whole company is using, so everyone's working on the same code base, mostly in C++ for performance and for performance reasons, but we also have bindings to Python for the more prototyping aspect of the work, and C# for the user interface, for instance. And so what I've just shown you is our software, which is called the Infusion Suite, which we use to do the prototyping and the R&D work. But it's the very same code behind the scenes that goes into our customer final application. And also we developed a number of tools to make our R&D even more efficient and agile. And this software Infusion Labels is one of those tools. Because early on, we noticed as data scientists or, let's say, machine learning practitioners that data is the core part of our work. And so it's very important to be able to understand how your data looks and whether there's any problems. So instead of having your data stored in a file, in a folder somewhere on your computer, we have the software that allows you to import all your images together with any kinds of annotations and visualize them very nicely in 3D. So you can just look at the whole database, you can mark some images, and in that way you can easily spot problems or understand a bit more your data, which gives you more intuition in the models you'll be training. This software is not just about visualization, it's also about annotation. So we have a number of tools embedded in that allow the user to actually annotate those images in also a very quick and efficient way. So those tools that you see here are mostly computer vision driven, so they're very generic. They can apply to any modality or any images, whether it's 2D, 3D, or 4D. And we have a number of tools that are more or less automated. Here you can see also some interactive segmentation where we just have to brush a couple of strokes in the different bones, for instance, of the city image, and then we indicate here that the rest is background, and there's an algorithm running in the background. And automatically propagates your annotation to the full volume. Of course, we're also able to handle video sequences and propagate annotations in the temporal sequence. So all this makes our work also a little bit easier. And this started as an internal tool, but we're also giving it out to our partners. Another thing that was very important and is pretty new is that I mentioned Python, which is very important to be able to try out new ideas. And our whole framework is now also available from Python, and that means two different things. So on the one side, we're able to import all our algorithms from a Python interpreter or Jupyter Notebook. So you can, if you want to use our registration algorithm, you can do it and call it in a couple of Python lines of code. But you can also extend our software. So the software that I've shown you, you just have to import a Python script where you've defined a specific class, and you can basically, your algorithm can actually show up in our software, so you can benefit from all our existing functionalities and visualization capabilities, and yeah, just integrate your algorithm in a more user-friendly way, maybe. So all this allows us to do research, and we can't publish everything that we do, but when we think we have a interesting and general idea, we do. So I just want to mention as a final thing 3 ideas, and one of them is about segmentation. So here we're just, imagine you want to train simple UNets for segmenting the heart structure in an MR scan like this. You want to work with at a resolution of 1 millimeter, which is good, but sometimes you have large volumes, you need a big GPU. And what we notice with our customers is that sometimes they want to integrate or run this model, either they want to try it out on their laptop, which doesn't have a good GPU, or within a test pipeline, so they don't want to spend a lot of time running those models. So what you can do is train another model that has been processing images with a lower resolution, so for instance 3 by 3 millimeter. But the problem is that you have to train different models and maintain them, and this is a bit cumbersome. So what's the idea of this paper is that we want to be able to have, with a single network, be able to configure the spacing it works at, so that it means basically you can tune based on your compute capabilities the precision with of the model with one single parameter. And the idea is very simple, actually. So it's based on the UNets, and the architecture is fixed. But what we do is that instead of training the UNet, we're training another network, so a hyper network, that is going to predict the weight of the UNet. And this hyper network is being conditioned by the spacing. So if you look at here, the input is going to be the target spacing, and it's going to go through a MLP, a very simple MLP that's going to configure the UNets. And the units, then you give it the image and you're going to get the segmentation. And with this approach, you can basically control the accuracy of your segmentation and your compute requirements. A second idea that we introduced last year was about registration this time. So we often have the problem of multimodal registration, where for instance, when you have here an MR scan and an ultrasound scan, usually registration is performed by optimizing, by solving a global optimization problem with a similarity measure. It can be mutual information, but there are more advanced or elaborate ones like MIND or LC2. And the idea here is, instead of training a machine learning model that would predict and give you the results, what we do is slightly different. We're training a model to compute those similarity measures in a much more efficient way. So those, instead of spending time to compare 2 patches in a very elaborate way, so here, instead of having LC2, which is a similarity measure between different image patches, we're training a neural network that is going to produce feature maps so that the dot product of those features will be an approximation of this complex value. And that means that it's going to be much faster to evaluate, and also as an added bonus, it's going to be differentiable. What that means concretely is that you can use then much more efficient optimizers, and you have a really high speed up. And what that turns into being able to optimize the problem in a much more global and exhaustive way, and you're much more robust to the initialization. So with this method, we had a 400 times speed up in computational time, and that means we can do global multimodal registration of 3D volumes in a few seconds, and that generalizes to any modality or anatomy, actually. The last paper I quickly want to mention was about this spine application I've shown at the beginning. The way it works implicitly was that we take the CT scan, we put it through a UNet, and that generates a heat map for the different vertebrae and the key points. But when you have this heat map here, in order to identify the different vertebrae, you need to cluster them together, like which key points go together, and which vertebrae is which, like this triplet corresponds to the vertebra T1 or C7, for instance. And this is not always easy. You cannot just count the number of them, because sometimes you have misdetections or you have problems in the vertebrae. And so the idea of this paper was to use a graph neural network to make this estimation more robust, so that we can really cluster triplets of key points that belong together, and we can correctly identify them. So yeah, that was just a small subset of the things we do at Infusion. I'm representing the machine learning team, but we have many other teams that work on very exciting projects: computer vision, ultrasound, X-ray, even robotics, or anatomy modeling. So if you're interested in joining us, if you're looking for an internship or a position, you can come to us at our booth, or you can check our website. And if you want to try out our framework or our software, you can just go to this page and you can get free licenses. With that, thank you.
Thank you. Thank you, Raphael, for your talk, and don't hesitate to submit to MIDL as well. Any questions from the audience? Yes, here.
Thank you very much for the presentation. I have a question, like for the interactive segmentation, for example. Would it be possible to host my own model on a server and attach it to your interface?
Yes. So this software, so it's a bit of an old interface, but actually this one is also extensible with Python scripts. So I can show you at the booth or something. You can just write, as long as you can put your thing in a Python function, you can basically execute it from the software.
I see. And is it possible to modify the graphical user interface? And if it is possible, with which language, Python or any other?
You can modify, so you can modify it in C++. And right now, Python is just about adding new ways of annotating. If you want to change more things at this point, it's going to have to be in C++, but it's possible.
Okay.
We've done it.
Thanks.
Am I last? Okay. Thanks for the talk. A quick question. We've seen a screenshot of 3D Slicer a bit before in some of the presentation. There are a lot of similarities here. What would you say are the main differences between your suite and 3D Slicer?
This is a question we often have. Yeah, no.
Why yet another one? Then?
No, that's fine. I can answer that. So 3D Slicer is very good. It's a very good software. We think within our team we prefer ours. Of course, we're biased, but we're not the only one using it. So we have partnership with a number of research labs that are actually using our software over Slicer. We're trying to be more and more open, which is why we're offering this grants program of so that people for non-commercial use can use our stack for free. also in terms of codes and integration, we think it is slightly better, but again, this is just, it's a preference, I think.
Thank you very much. If you don't mind, I think we're going to move on. Thank you again, Raphael.
Sure, thanks.
We're going to move on to the last sponsor presentation. This is AZMed, our silver sponsor, and we're having Arnaud Abreu, head of AI at AZMed.
Thank you very much. We are quite happy to be sponsored at MIDL 2024. So thank you. I want to thank the organizer for letting me speak today. I will be brief, and this will be a very quick presentation, quick overview of what we do and who we are at AZMed. So first, let's talk about why AZMed exists. So at the beginning, when we founded the company, we saw that there was a slight difference between the increase in medical imaging exams and the number of radiologists in terms of increase. So a slight difference. One is increasing much faster than the other. And the practice of detecting and diagnosing radiology images, standard radiology images, is very error-prone and time-consuming for radiologists. So there is a real interest in trying to make their decisions better and faster. So that's at this point that the founders wanted to start the AZMed journey. So our goal basically is to produce AI models to help radiologists to have better diagnosis and faster. So now I will talk a bit more about our project, which is called Revolve. So Revolve is basically an object detection framework. It's used to detect a large variety of pathology in standard X-ray images. So basically, we do automatic detection of fracture and other pathologies in limbs, but also in chest images. We do sort exams by priority, and we are smoothly integrated in the workflow of radiologists. So we are, for example, we are connected to the PACS, and we we collect the images, predict, and put the predictions on top of the images for the radiologist. So basically, we just put bounding boxes on images to help the radiologist to spot the lesions. So we do have partnerships with a lot of university hospitals as well, in order to make sure that we do not develop or a product or a feature that's useless for pathologists. So we try to back everything we do on every task we do on any pathology by clinical studies to make sure that we are truly helping the radiologists. So many things I already said in that slide, but here so the complementary information here is to say that we are very fast at predicting, and every algorithm we have is adapted to the center where it is deployed, which is something I will technically explain later. Just a word about the team. So we are 40 people. organized in a functional organization. So we have quality and regulation, which is very important when you sell a medical device. We have, of course, sales people, software engineers, and an R&D team, which is the AI team. It's the core team of the company. This team was founded at the very beginning of the founding of AZMed. And you can see that many of the people working in the team are senior data scientists, and they actually started their career at AZMed for most of them. So they are growing their experience and their researcher abilities in AZMed pretty as much as they give and make grow AZMed. So just a few words about the tech we use. So this is the traditional process of selling predictive algorithm for medical devices. So what you do is that you collect a lot of data from multiple centers. You train an algorithm on that huge data set, and then you deploy the algorithm as is to the different centers. What we are trying to do in AZMed is to have one different algorithm for every center where we deploy, because we believe that we necessarily have to adapt to every center. So what we do at AZMed is that we collect also a lot of medical images, but we train a lot of models on top of it in the R&D team. And what we do when we deploy to a new center is that we find the optimal combination of models, but also of hyperparameters that will work on the new center. This is also a strategy to correct biases and to be able to adapt without retraining systematically the system. Of course, we build data sets, so we have something like 15 million images in our database. It's a diverse database because we do not only collect images that we use in production. We also collect medical reports and CT images as well. We started collecting them. It's also diverse because we have many pathologies and not so many modalities, but many pathologies. So fracture, but when we are dealing with the chest, we also detect nodules, pleural effusion, and different pathologies. And every image that is labeled in the database is labeled 3 times to make sure that we have all the information and very cross-checked information on every images. Of course, we do have AI challenges. So we always have to boost the performances of the system, so the time to infer and to predict lesion on an image, but also the accuracy and the sensitivity and specificity of our models. We have to, and this is probably the most difficult one, I would say, maybe not the most important, but the most difficult one, is to adapt and generalize a lot. So we deploy a lot of technique when we train, a lot of them. So we basically implement new papers every month to be able to have a training procedure for our new algorithm that maximize the generalization abilities of the models. And of course, we have to reduce annotation as much as possible because labeling medical images is really is not cost efficient because experts you take time of experts and it's always super costly. So we try to work on methods to be able to train model on less annotations, or also non-exhaustive annotation, which is kind of a different application. So thank you very much.
Thank you.
If you have any questions.
Yes, we have a question here.
Hello, thank you very much for your talk. It's really interesting. I was just really interested in the slide where you say you have multiple algorithms which you use, which you select and then find the appropriate one. I just wonder, under current regulations, like I think you're supposed to submit a model, that model's fixed, and then that's the model, at least, you know, maybe in Europe and the States. How do you go about that here? Because I guess all the models will have different weights, and therefore technically might not all be cleared models.
I'm sorry, I didn't get the last part of your question.
I'm just getting all these algorithms are probably going to be have different weights.
Yeah.
And therefore they might not be cleared algorithms, because cleared algorithms might have fixed weights, like if they're FDA cleared or CE cleared. I just wonder how you go about that issue if you're selecting different models. Can't clear all of them, or have you cleared all of them?
So, of course, we made sure on the regulatory side that we do not have to resubmit everything every time we change a weight in the model. Actually, those models are frozen, and what we do is the combination that will be different. And currently, the process is to collect images in the new center where we have to deploy. But it will be only a validation set and not a training set, where we will just random search for the right combination and the right hyperparameters, but we do not change the models at all. So, and I don't have the details about the quality and regulation system we use to avoid resubmitting every time we change the algorithm, but actually that's the case.
Yes, another question over there.
Yes, my question is also about the automated selection of the algorithm. So you just mentioned that if you go to a new hospital, you gather a validation data set. Do you label that data then yourself, or do you ask the hospital to provide the labels for that?
I mean, well, it's always better if the hospital labels it, but usually we do it ourselves. So we have our annotators, and we do have a medical team to annotate the slides, or we pay a contractor, an external contractor to do it. Yeah.
Right. Thank you.
I think we are going to thank you again. And then there is this a coffee break right now, and then a poster session. Thank you, everyone.
Okay. Good afternoon, everyone. We will start this afternoon session. Okay, it is my great pleasure to introduce today's keynote, Laure Fournier, who is a professor in radiology at the Hôpital Européen Georges Pompidou here in Paris. So her time is divided between clinical work on urogenital cancer and imaging research in the Laboratoire de Recherche en Imagerie. She works on functional imaging, radiomics, and big data to extract quantitative parameters from images reflecting tumor physiology and biology. She also organizes a curriculum on artificial intelligence for French radiology residents. She's a member of the scientific committee of the DREAM France AI National Image Database and is a medical imaging chair in the Prairie Interdisciplinary AI Institute. She's been involved in outreach activities, including roundtables with clinicians and policymakers, meetings and interviews with patients and general public on the subject of patient databases, radiomics, and AI. So, Laure, please, the floor is yours.
Don't clap before the talk, you never know. You might be disappointed, right? So thank you very much to the organizers for inviting me. So I'm like your friendly neighborhood radiologist here to talk about the clinician point of view on AI in medical imaging. I also want to thank my colleagues, Guillaume Chassagnon, Constance de Margerie, and Loïc Duron, who contributed a few slides and are also always happy to brainstorm with us about all these questions. So what I'm going to cover is kind of vast. I called this so near and yet so far. So the first part will be on what works, what we are actually using in our clinical departments, and then the big issues. And I know you are all very familiar with this, but I'm going to try to give you like the doctor's point of view. Of course, I have quite a few talks and research collaborations on the subject, so these are my conflicts of interest. So just to do a little history, us radiologists were quite used to this computer-aided diagnosis stuff, right? Because it all started in the years 2000 with screening mammography and computer-aided detection. So we've already heard several times that we're going to disappear. But what happened at the time was that people were very excited about this, and they were so excited that actually in the United States there was a funding that was dedicated to encourage radiologists to use this. And then several years later, the studies sort of showed that actually this was not really helping radiologists, that maybe the accuracy was decreased when we used them. And the reason for that was because most of these were very sensitive but not quite specific enough. And of course these were based on traditional machine learning. And in the end there were so many false positives that it actually had a negative effect. And then we sort of entered that AI winter in radiology, and then it came back to hit us in the face in a kind of violent way, I must say, with all these people that you've heard of who started declaring once again that radiologists were going to disappear. And so even if we weren't into AI, well, we really could not ignore the new developments. And of course, these new developments were really linked to deep learning. So once again, we were faced with extermination, and contrary to the dinosaurs, we are trying to do something about it. But actually what happened is that it brought a lot of attention on medical imaging, and I want to thank these people who did not mean to be nice, but in the end kind of helped us out. It brought us the attention of you guys, all the people, all the brains out there that are interested in imaging and that wanted to work on medical imaging. It brought the attention of funders, whether public or private, and of course, as I said, it brought the attention of a lot of radiologists because we absolutely cannot ignore what's going on in that field. And of course, once again, you guys are all comfortable with this, but it is very obvious why what happens in the natural imaging domain where, for example, when you're looking for signposts for your automatic car, you're going to be doing a detection task, then a classification task, and this is very easy to transfer to medical imaging, at least on the surface, where we are going to, for example, in these mammographies, have a first task looking for a lesion or not, and then classifying it. So that was my nice little introduction, and basically that's where we were at, let's say around 2020 or something, maybe a little before, 2018. And as you see, I have kind of an inflated ego as a radiologist, but the real question is the superhero actually AI and not the radiologist? So let's see what we're using AI for today. Right now I'm going to talk about what either actually works in the clinical setting or what will work really soon, or this is of course my opinion. Let's start first with detection because that's what everybody always focuses on. The two most used applications over the world are these, and these are definitely in the clinical setting. It's detection on mammography and detection of bone fracture. And I guess you have to sort of think like why these two specific applications. There is a series of reasons, but maybe the most important reasons are that first of all, it's a single task when you're looking at these images. I might have also added that there aren't that many images compared to an MRI or a CT. And the other thing is we do have large amounts of data available for breast because there are screening programs, and for bone fractures because this is the first reason to do an X-ray in a radiology department. So probably this has favored the development of these two applications. And I can say that some people are actually buying these, which is probably not the case of most other applications. These will very quickly move on to lung cancer screening and chest X-ray, I believe, because these are quite mature already. So when I was thinking about what really works and what doesn't work, I wanted to distinguish maybe three sort of cases. The first case is the screening case, and I call it the calculated risk. Can you see my, yeah, the calculated risk. What I mean by that is that even if AI does errors, this is a risk that you can incorporate when you're deciding the balance between benefit, risk, and cost, right? Because breast cancer screening programs balance these three items. And so we know that some cancers will be missed or there will be false positives, but this can really be incorporated in that calculated risk. The second type of application is what I call suggestion applications. In that case, the AI proposes a diagnosis, but it's sifted through by humans. So the human control is very strong, and that way it's very easy to implement and to accept. Now, I put on the far side prediction, which is not really detection, but it's the consequence of detection, just because I didn't really know where to put it, but I wanted to underline that this, I consider, is a very high-risk situation. It's a high-risk situation because you're predicting the future, and though I am a superhero, I do not know the future yet, and so human oversight is impossible, particularly when you're talking about prognosis, survival, predicting life expectancy. Obviously, I cannot judge whether the AI is correct or not, so these, to me, are kind of dangerous applications or things that are going to be difficult to implement with a lot of confidence. So just to underline what's going on in the breast screening world, this is a study that was done in Sweden on a breast screening program with almost 15,000 women. What you have to know is that usually in breast screening there are 2 readings by human readers, so that it can increase the sensitivity of the screening. And so they did a study where they replaced AI in different places. So there's the AI gatekeeper, which has high sensitivity, and all normal cases will not be seen by a human. There's the single reading plus AI, so basically you replace a reader by AI, and then you go to a consensus. There's high specificity AI, where the AI would be a standalone solution, and then there are the reference sort of things where there are only humans that are implicated. And what was interesting in the result of this study, if you use the double human reading as a reference, was that if you look at AI alone, unfortunately, there's a loss in sensitivity. So they considered it was not a good solution, other than the regulatory aspects. If you look at the AI as a gatekeeper, this was rather efficient. The only issue was that there were a certain number of cases that were never seen by humans, and that might be a limit to the acceptance. And so to them, the most acceptable solution was the single reading with the second reader being AI. And this is really something that we feel that we are going towards. Now, regarding the kind of suggested applications, as I called them earlier, one of the things that people are starting to use are triage. So the idea behind that is that the algorithm works in the background and flags the abnormal studies. So for example, it could be brain hemorrhage, like on the left, it can be thorax or vertebral fracture, whatever. But the idea is that it's flagged. And so it's kind of neutral. It's just telling you, look at this one, and then of course it's the human that goes behind that. The second application is something that I work on, and I think maybe Camille and Florence are here, with them at the LIPAD and with our PhD student, which is content-based image retrieval. And the idea behind that is the Google Lens of radiology, which is you give an image to the system and it will go look into your PACS or your database for similar images, present them to you. And the advantage with that is that some of them might be wrong, some of them might have nothing to do with it, but it doesn't matter because once again, it's the human that's going to sift through these and select the relevant cases. And then if you move that concept to a larger scale where you take both imaging and any other data, well, you're moving towards the digital twin, right? And the digital twin is taking all the aspects of one patient and comparing it to the other patients in your database. And this, of course, can include medical imaging. So that was for detection. Now, the other big application that we're using every day in clinical practice is segmentation. Of course, I'm not going to tell you that it works really well. And just for the purpose of this talk, some historical examples. These are two aspects where we are using segmentation, deep learning segmentation, the cardiac MRI here to measure volumes, for example, and also segmentation for radiation treatment planning. So these are very efficient solutions. We know that they're more reproducible than humans, and of course, the interesting part is the time that you gain by using these. This can be extended. I'm just showing you examples of things that we have. Well, the top one is commercially available from Siemens, where you're going to have a segmentation of practically everything that you can segment in the lung. So you have a kind of comprehensive view, nodules, emphysema, lung total volume. And at the bottom, an example from Philips, where all the organs are segmented in the case of this, this pancreatic tumor. And this allows a 3D reconstruction for surgical planning. But beyond that, what is coming up in the radiology world is what we call opportunistic CT screening. The idea behind that is when you do a CT for a patient for a single reason, there is actually a lot more information that today radiologists are not exploiting because they don't have the time or the tools to do it. And so the idea is if you come for an appendicitis, for example, well, if you do appendicitis, you won't have your lung, but we could look at everything else in your body. We could look at your cardiovascular calcifications, we could look at your muscle, we could look at your lung, et cetera, and find things out about your health. And that way, it would screen for diseases or for high risk of disease, and this would allow what we're hoping, which is preventive medicine. That means reaching patients before they are actually ill and putting in place certain follow-ups or whatever, or treatments, for example, in a high-risk cardiovascular. But beyond that, so these are the things I think that you are all very, very comfortable with. Beyond that, the whole workflow of radiology can be impacted by AI and is being impacted by AI. There is what happens before the actual exam and what happens after the actual exam. So, before the exam is image acquisition, and we have now applications that are in our devices for patient placement, anatomical coverage, and checking that it is correctly done and you haven't cut a piece of the lung, and slice placement. And just to be fair to all the manufacturers, this is an example from General Electric, where there's an automatic slice placement, for example, in the plane of the optic nerve. And this, of course, increases both reproducibility and gains time, just like for segmentation. There is also applications in image reconstruction, and you may or may not know that most of our devices now include deep learning-based reconstruction of our images, which allows much better noise reduction and artifact reduction. So either you can improve noisy images, or you can even acquire lower quality images and then improve them secondarily. And this will allow, or already does allow us actually, to decrease acquisition time, decrease radiation dose, and also decrease the dose of contrast agent that we're injecting. So as I said, I wanted to be fair with all the manufacturers. Canon was the first to embark deep learning reconstruction in their CTs. Once again, historical examples of undersampled MR imaging that can be reconstructed using deep learning. Also, reduction of radiation dose. So these were the first tentatives in the field, and you can see that the reconstruction image is not quite extraordinary, but today these are embarked in our machines, and we use it daily. And there is also contrast agent. We can really reduce the dose. For example, the CT that we're using currently, we've reduced the dose of contrast that we inject by 30% already, and I think we can still go down some more. This was an example in MRI where there was only 10% of the contrast agent that was injected. This is a synthesized image. You can see this little lesion here, and this is the full dose image. So it's not quite perfect, but it really has been improved since then. And then finally, you can actually find new information, and this is an application where you reconstruct bone CT images from MR images. And the idea behind that is that the MR doesn't really give you information on the cortex of the bone, on the cortical bone, whereas CT does, and so sometimes you have to do both exams. And the idea behind that would be to be able to find that information directly in the MR rather than have to do a CT scan. And then finally, downstream from the image interpretation, there is everything that we can do on text, and also using that link between text and images. So there is, and I'm imagining that you are probably all familiar with this, but the automatic generation of reports from annotations that the radiologist would do while he is reading the case. This is an academic paper, and this is a commercial solution. But there are lots of other ways to use this. There are automatic transfer of results to clinicians, especially if there are actionable or urgent results. And so this allows timely communication. And there's an application on brain infarct that is actually functioning in the States particularly. There would be something that people are starting to work on, which is a kind of automatic translation of our reports into lay language for the patients. And then this also allows both quality control, standardization of terms, checking that its conformity to quality criteria, and eventually the flagging for a junior when a senior reading has changed something so that they can, automatically find the cases where they have to improve. And this is an interesting paper that came out recently where they compared radiologist-generated reports to ChatGPT-generated reports. And these are the appreciations of clinical urologists when they read the reports, and you see that they found them more relevant, more correct, structured, easy to understand, et cetera, et cetera. Of course, these ChatGPT reports had been checked by radiologists to make sure there wasn't anything completely wrong in them. Okay, so this was, what are we doing today? Are we using AI? So you see the answer is, yes, we are using AI. Maybe just a little in detection, which is kind of the big application that we always think of, but in lots of other aspects of our workflow. So that was the so near part of my talk, and now we are going to get the, do we feel that we're still a bit far before complete integration and large-scale integration of AI in the clinical context? So this is just, once again, for a little history. I mean, I already went over this, but, and I'm, of course, I'm not telling you guys about this, but we know that, like, at the beginning, it started with image processing, et cetera. We had those rule-based CADs that came up and that weren't working perfectly well. But really, we all know that between 2000 and the years 2010s, et cetera, that's when things really took off with the development of neural networks. But what I wanted to underline, and I want to thank Constance de Margerie for this, is that these years, now that we feel that the technical aspect is not, of course, it's not finished, there are lots of evolutions, but it's getting close to maturity. Well, all the other questions are coming up, and these questions are, how do we integrate multimodality, how do we validate all the regulatory aspects, and the ethics and security? And really, this is the time to really be thinking about this aspect, because these are the things that are now going to block partially the integration of AI in our workflow. So I'm going to go over a certain number of questions, some of them quite quickly. The idea is that I don't speak too long. I keep some time so that we can have this discussion at the end. But the things I wanted to underline were the clinical question, the data, of course, the confidence, the ethics, and the integration. So just for the clinical question, one single slide. Of course, we all know now that it requires collaboration between doctors and data scientists. I mean, it's so obvious, but I think it's important to say because this was not always the case, let's say 5 or 8 years ago. The important thing is that we have to find the right question, and a question that is actionable. There has to be a reason for doctors to use it and for organizations to pay for it. So the actionable means, will I change patient care? Will I change somehow the organization? And what is the benefit that I'm going to get? Is it time? Is it money? Is it security? Whatever. But we have to really think about that. And though it seems quite obvious, it isn't always that obvious if we're gaining stuff, and we'll see that later. One of the big issues is the multiplicity of questions. What I mean by that is, if I have a CT or an MRI, whatever, of course I have one central question, but I often have secondary questions, and then I have the unexpected questions, right? And AI right now is having a little trouble dealing with that multiplicity. Regarding data, so I'm not going to go into that because we've just talked our heads off concerning data, both in terms of how do you get enough data and how do you get good data. So I'm just going to say a couple of things. First of all, and if you work on medical imaging, you are aware of this, but data changes very fast in medical imaging. First of all, it's hard to get data that is relevant across institutions, across countries, et cetera. But there is a very rapid turnover of therapies or patient management strategies. And there's also rapid turnover of techniques and imaging devices. And all this contributes to the fact that it's really hard to get both relevant and large data sets. Of course, I'm not going to go into the regulatory issues. We've all had terrible headaches with that. I want to have a positive note. And so the positive note is that Europe has realized that there is a real problem around health data. And so there are several things that have been coming up. First of all, the European Health Data Space that was announced in 2022 that has a goal, well, for patients being treated and them being in control of their own health data. But for us, what we're more interested in is that their second goal is improving the use of health data for research. Yay. We're waiting for the results, but at least they want to do it. And so if you look in detail, and on the previous slide there's the link, but you can just type that in and you'll find it. You see that it's meant to be very controlled, but that the access is supposed to become decentralized and a bit simpler for researchers. The second aspect at the European level is the Data Governance Act. Interestingly, they say that GDPR may not be very well adapted to health data sharing. Yay, we could have told you that. So they intend to make what they call more tailor-made rules for the health sector. So same, we're waiting very eagerly for this to happen. And the third thing is that, and I mentioned this before, there is a lot of funding coming from Europe, and they have a coordinated plan on artificial intelligence, which is meant to accelerate research, industrial development, etc. And so all of this is kind of converging, and hopefully, you know, maybe in a couple of years, we'll actually think that this data problem is in the past. Okay, I'm very optimistic. So that was access to the data. Then there's the aspect of the quantity of data, because even if we do have access, can we get large-scale data sets that are relevant, as I was saying? Well, maybe the solution is just working with less data. Please tell me you've got that in the works, because I'm not super optimistic about having giant data sets other than certain clinical cases. So of course we know that we can help by doing data augmentation, but even with the recent developments, it does seem that we're never going to actually reach that natural diversity that we would have if we really had complete data sets, natural data sets. Of course, there's transfer learning, which can help us, and then there's the concept of small data, and Andrew Ng from Stanford had given a talk, I think last year, or actually 2 years ago already, saying that the way to go in health was actually to just have smaller data sets, but very high quality, and work from there. So that's another, but you guys are the ones who can tell me if this works. As I said, I didn't want to spend too much time on data. I want to spend more time on things that are really issues for the doctor when they're using these solutions. The first issue is confidence. And I use that word, which is a very general word, but voluntarily. This will cover explainability, error detection, traceability, how do you validate, etc. So I'm just going to touch upon these points. Of course, each of them could, be a whole talk in itself, but this is just to kind of foster the discussion. So of course, everyone knows this, right? You can cheat an AI system by making him think that this is a toaster, and of course, everyone always thinks this is very funny. But when you're a radiologist, it's a nightmare. Because when it becomes this lung nodule, well, I have absolutely no idea that the AI is completely wrong when it tells me it's benign, right? And let's say, when is this dangerous to us as a clinician, and why are people stressed about using the AI solutions? Well, it's dangerous when we feel that these errors are random. That means we can't predict them. Because if we could predict them, then we could learn them, right? We have artifacts in practically all of our imaging techniques. An artifact is something I can predict, that I learn to recognize, and then I can put it aside. If it's random, then I just don't have any way of predicting it. It's dangerous when it's realistic. I mean, of course, a toaster versus a cat is not realistic, and some of the mistakes the AI makes are not realistic, but sometimes they are, just like those ChatGPT bibliography references, the ones that they pull out and they look super real. And of course, that's not so funny when it's an image, a medical image. And as I said earlier, when it's not verifiable, because I guess you can say, well, we can just follow up these nodules, right? And eventually either we follow up or biopsy it and we'll have the answer. So in a way that can be solved. We don't want it to happen to too many people, but it can be solved. But if we're going into survival prediction, as I said earlier, this is not verifiable. So if it's something that I can't verify, well then, of course, this will be a real difficulty for us as physicians. Regarding explainability, I'm just putting up things that are out there, right? But once again, you guys are the experts. I think we do need these. A lot of us like these occlusion maps because they're so easy to understand. The thing that I'm not completely sure about is how true this is, if there can be artifacts, errors, or misleading things in these occlusion maps. So I think if we start using these, we will also have to understand whether there can be caveats to their use. Then there's traceability. So what do I mean by traceability? Well, as radiologists, I think it's very important that we are aware of the data sets that we use, both for training, validation, and tests, so that we can compare it to our patient population, of course. We would like some of these systems to actually try to go further than correlation, but try to go into causality. And of course, this is complicated, but this is definitely something that would strengthen our confidence. I also believe that the evaluation metrics that we use today, which is most of the time AUC, you know, F1 score, whatever, is very partial. It only gives one part of the information. And I think we're going to have to work on how we can present these metrics, both so that they're more clinically relevant and also more easily understandable for the lay radiologist. And then, of course, we need to make sure that there's a tracing of the evolutions and the feedback. But I wanted to show you this paper by Cynthia Rudin, who works at Duke University and has been working on medical imaging for years. Some of you may know her. And she actually says, let's stop this black box thing. If we have a very important decision to make, then it has to be explainable. So this is just to put it out there. You know, deep learning maybe is not the answer to absolutely everything. And then the last stage is validation. And validation is also a challenge. So this is a paper that came out quite a while ago and that said, okay, if we want to validate an artificial intelligence tool, then we have to have these clinical trials that either randomize the patients with or without, or that have different series where you use it, then stop using it, then use it, and then stop using it. The thing is, these are not very easy to implement, and I'm going to put a slide in French. I'm sorry, but it's just, you know, it's like the subway map in Tokyo, you know, when people show that. This was the workflow of a clinical trial that we put together with an industrial partner. It's just to show how complex it is. Because if you want to show a benefit in the end, you have to imagine every single pathway that it can take, every single possibility, and see where the biases can be, et cetera, et cetera. So to be very honest, these clinical trials are theoretically simple, like the previous slide, and then when you try to actually implement them, it gets a bit more complicated. So this is also something that makes it difficult to foster confidence, because we're having so much trouble validating these, you know, beyond sensitivity and specificity. There are lots of burning questions on the validations. How many sets or how much data are necessary? Of course, we have that, you know, training validation test, but we know that one test set will never be enough. But is it 2? Is it 5? Is it 50? Do we have to do it every single time we install the AI solution in our department? I don't think anybody has that answer to that. And of course, I already mentioned the fact that things were shifting. So, you know, when acquisition techniques change, when are you supposed to reevaluate it? You know, when populations change, when are you supposed to reevaluate it, et cetera, et cetera. And of course, you probably all know this paper in arXiv that showed that, you know, ChatGPT's performance has changed, and these are the evolving, let's say, AI systems which we're not supposed to use in health, but it just shows that it gets better in certain fields, gets worse in others, et cetera. And this is obviously something that will preoccupy the doctor when he's using this solution. You know, is it still working today the same as it was working a year ago? Now, when we look at the literature and are we good at this validation thing? Well, this is a paper that looked at 224 medical AI companies, so this is not just medical imaging. There's lots of different applications, prevention, diagnosis, therapy. There are also some applications that are destined for the general population and not the physicians. But what was interesting in this paper, so it's going to be a bit busy, but what I wanted to underline was that they evaluated the clinical robustness of these papers, and specifically if there was a regulatory submission and if there had been clinical trials. And you see that 44% of these solutions had a score of 0 on clinical robustness, and that there was, let's say, a discrepancy between the clinical claims and what was actually proven. And so they also underlined the number of cases where there were you know, issues regarding deceptive claims, and their conclusion was that most of the digital or many digital health companies have a low-level clinical robustness. So we definitely have to work on that because these, I mean, if we want to use these to the benefit of our patients, then we definitely have to go the whole way when we are validating these systems. And the last aspect is the economical aspect and the cost effectiveness. And so this paper was checking to see if there were cost effectiveness studies, and basically the conclusion was no. Some of them did evaluate some kind of cost effectiveness, but they considered that no study was complete. There wasn't a single one that took into account the cost of the infrastructure needed to implement the system, and we'll see this when we're talking about integration, but this is a real issue, and most of them did not compare to other solutions. Now, the last aspect of confidence is how will AI impact human performance, right? Because we said, okay, it's not going to be a standalone AI, it's going to be an AI that the human uses, but how will this affect our performance? And remember that CAD, that slide way at the beginning that said when radiologists used the CAD, they were worse, or they had worse performance than when they were alone, right? So we don't want that to happen with our new applications. So I'm going to show you a series of papers that are quite interesting. It's a bit difficult to realize exactly how we're affected. So this one, it was a kind of fun paper just because the title is nice to start with, Do As AI Say. And they wanted to look at how people were influenced by AI, and particularly, so what they did is they had these chest radiographies with reports. Some of them were real, some of them were fake. But what the thing was is that radiologists were randomly informed whether it was a human that was giving them the suggestion or whether it was AI that was giving them the advice. And so they looked at whether that influenced the radiologist. So the first thing that you could see is that when you're a radiologist, you're less influenced by inaccurate advice. So that's a good thing. That means you can tell that you know, whatever they're telling you is wrong, whether it was a human or AI. There were also internal medicine specialists and emergency specialists, and they were rather more confident in the advice that was given to them, whether human or AI. And the second thing was when you're a radiologist, you tended to trust humans more than the AI. It's not very significant, but it's there, whereas when you're another kind of specialist, then you just trust everyone, I guess. But we're going to see that there are very different results according to the papers. This is another kind of nice paper that came out recently, or last year, I think, on the reading of mammograms. So what happened was there were 50 mammograms, 10 were given that had AI giving advice that was the right advice, and then randomly 12 mammograms that were inaccurate and 28 that were correct. And these were read by some radiologists. So what did this study show? So what they were interested in was the experience of the radiologist. What it showed was that if you're an experienced radiologist, this is the reading time. First of all, you spend a lot more time on the image, whereas the other ones maybe, I don't know, trusted the AI, and so spent less time reading the image. So that was kind of interesting. And the second thing is, and this makes sense, was that when the AI suggested the correct category, everyone agreed with that, but when it suggested the incorrect category, well, obviously the more experienced radiologists caught that more often than the less experienced ones. But in this case, this is another paper which wanted to look at the predictors of the effect of the AI assistant on radiologists. So it's still the same idea, how do the humans change eventually their interpretation according to the advice of the AI. And in this case, and it was much larger because there were 140 radiologists and 15 different tasks, they showed that actually it didn't look like years of experience, subspecialty, or familiarity, or whatever, really impacted the fact that you trusted the AI or not. So these are a bit contradictory studies, just to show that we don't know everything yet. They did not find that lower performing radiologists benefited from AI assistance. But what they did show was that when the AI was wrong, it affected all radiologists, more or less, but it affected all radiologists. So their conclusion, and it sort of sounds kind of obvious, but is that when the AI is good, everyone is improved, even the experts. But when the AI is bad, well, everybody goes down, even the experts, which is not completely contradictory with what we saw earlier. So basically, we need good AI systems. Wow. But it's important to show that. And then the last aspect is something that was published by our friends, Guillaume Chassagnon and their team, about can AI help residents learned to read chest x-rays. So basically, the residents read x-rays without AI, and then they were given the AI as a ground truth so that they would learn to see anomalies on the chest x-ray. And then you took it away, and they reevaluated chest x-rays. And what was shown in this paper was that actually they did not get better. They got better when they were using the AI, but they hadn't learned anything. They don't gain skills with this AI, because when you go back without AI, well, they just have the same performance as before the AI. Okay, so that was the confidence, and now I'm getting to the end, well, with two still big things, of course, the ethics and the integration. Now, regarding ethics, I'm just going to show you two aspects, so two documents. So there are the ethics guideline for trustworthy AI that underline key requirements, what they call key requirements, which are human agency and oversight, technical robustness and safety, privacy and data governance, transparency, diversity, non-discrimination and fairness, and societal and environmental well-being impact, and then accountability. So these are the items that the European Commission considers is obligatory to have trustworthy AI. And of course, we talked about a certain number of these, so I'm not going to go over all of them. I just want to show you the French, the issues identified by the French Ethics Committee. In this case, it's more about what are the risks of AI, and you see that it overlaps partially, not completely. Of course, you know, performance has to be good, there has to be human oversight. They underline, again, the fact that the tool should be used as aid and not a substitution. And they clearly state that the health considerations should supersede the economic considerations. They also want to be alert on the risk of use by the health insurance companies, and of course, the issues of responsibility. Just to go back to that human oversight, there are cases where it might become acceptable to have standalone AI or autonomous AI. The World Health Organization guidelines on the screening of tuberculosis recommends in places where there are no radiologists that AI be used alone. The only thing that we have to remember is that these populations are probably not present in our training sets, right? Because these populations are the ones that do not have access to health systems, right? So we have to be careful, and we'll probably have to control these systems quite frequently and early on to make sure that they actually perform in these populations the same as the training ones. Regarding fairness, and once again, I'm sure you're very aware of this, but I found that this study was quite interesting. We also all know that when you do medical imaging AI, often it leverages what they call demographic shortcuts. So things that are in the image about age or race or sex or whatever that come into account in your model. And so, of course, that means that populations that are not in that demography initially will not be treated equally, let's say, by the AI system. So what they showed in this paper was that you could algorithmically correct those shortcuts, and in that case, on your data set, it will, let's say, equalize the treatment according to all these demographic items. However, when you apply it to a new data set, well, the demographic aspects take precedence again. And so to them, it's really important to make sure that your AI model does not embark, if possible, those demographic attributes so that you can, you know, try to tend towards a more fair AI solution. And I'm not even going to go over this. I'm sure you're much better aware than I am of the very high consummation, but this is an ethical issue that we do have to take into account. Now, the last part is the integration. And it sounds like the boring part, right? Because we like everything that happened before, you know, it's intellectual, philosophical, everything. This is just like about getting the thing to work, and it's kind of nitty-gritty, first of all, where do we put that AI? And according to where we're going to put it in the workflow, we're going to integrate it in different places, right? And this was probably one of the first papers that came out on how to integrate AI in the radiological workflow, you know, before, after, at the same time, whatever. But I'm just wondering if we don't have to invent a new workflow, because this is very standard, but maybe it's not the ideal way to work. So we all have to sort of try to think out of the box on that one. Regarding the workload, this was a paper that evaluated over 400 studies to see if we considered that it improved the workload for radiologists. First of all, they showed that at the time, only 65 of the applications actually led to some kind of impact on patient management. But more importantly, about 50% of them increased the workload for the radiologists. So this is definitely going to be an issue. Of course, if the benefit is high, then radiologists are ready to put that extra time. But if the benefits are low, then we're not going to spend that extra time. And if you're interested in all the integration issues, please read this if you haven't read it before, To Buy or Not to Buy. It's all the aspects, everything that should be checked for an AI solution to make it worth spending the money on. And there are lots of things, I'm not going to go over everything, but lots of things about the integration. These are the things that I wanted to underline. First of all, we need it to interface seamlessly with the PACS. The PACS is what we work on every day. We need it to be in there or easily accessible so that it will improve or at least not impede our workload and workflow. But of course, this poses security issues because every time you plug something in, it's a possible security breach, right? Second aspect is who sees the results. Do the results of the AI solution, is it readily accessible both to the patient and the corresponding clinician? And this can be an issue because if you negate an AI result and you have a human-AI discrepancy and it's out there, then you might eventually be asked to justify it, and this can put the radiologist in a difficult position. And then what happens if there are maybe wrong decisions that are made because they have access to the AI result, but it's wrong and they make the wrong decision? What's going to happen then? So these are issues that are still out there. It really depends on the type of solution, but these are things that radiologists are preoccupied with. Now, how do you function if the product is out of order? You know, whether it's because it was hacked or whether it's because there's a technical problem. And will your workflow function normally, or at least subnormally, if you don't have that AI solution, right? And then, even worse, does the radiologist have the necessary skills to work without it, right? Because today, us radiologists, we've been learning radiology without these, but when we start learning radiology with these solutions, well, what happens when they don't work? And then the last thing, and it is really not the least, is the cost. Today, to me, the economical model is totally unrealistic. If I want to cover all my CTs, all my information, I would need 50 AI applications, and I cannot spend that money on it. So just to finish up, this was a survey that was done on among European radiologists. There were about 300 that answered in a lot of different countries, over 30 countries, a lot of them public or academic radiologists. The important aspects, let me see, I'll just move on directly to that, is that first of all, most of them did have the impression that AIs had pretty good performances, and yet 18% of them said they had technical problems for installation, and I think that's kind of optimistic, to be honest. 70% of them said there was no improvement of their clinical workflow, and 80% would not buy the solution, okay? So even though it's working pretty well, they don't buy the solution. And you have to wonder why. Well, they consider there's no additional value. They're doing pretty well without it. Sometimes it doesn't perform as well as advertised. That's probably generalization problems. Or it adds too much workload. Okay, so we really have to solve these problems if we want radiologists to use these. And so I get to the conclusion, finally. So in conclusion, what can I say? Well, first of all, are we being unfair with AI? Because to be honest, I've been criticizing, well, I said there were some things that worked well, but globally I've been saying there are lots of things that are still issues. Are we setting a higher standard for AI than for any other medical application? For example, in drug clinical trials, well, we know they don't always translate in a benefit in overall survival. We know they don't always or practically never generalize to larger populations, and we know that they're not inclusive and fair. And regarding our current diagnostic tools and imaging, well, they're not all explainable, so why are we asking AI to be explainable? They also make errors, but maybe, as I was saying, these are more deterministic errors, so more easier to understand, and they're not reimbursed either. But let's just finish up. So today, what works? Reconstruction, segmentation, and detection in a certain context. What will soon work, I think, if we can integrate them correctly, is reporting and opportunistic quantification. What might never work or later work, I don't know. Autonomous detection, versatile detection, and I think you got that I wasn't crazy about prediction. This is my wish list, so I'm giving it out to you. This is what I would like for Christmas next year. I would like these to be trained on smaller data sets and able to do a lot of multitasks. I would like to be given a confidence score that often exists already, but also to exclude the out-of-distribution images and just tell me, no, I'm not even going to look at this. And of course, I would like a seamless integration with my PACS and, if possible, very cheap. Okay, and so just to finish up, we all know the hype cycle. This is the one for artificial intelligence. I'm not sure it's the latest one, but what I wanted to say is that this goes up, down, and back up, but actually I sort of feel like we're on a roller coaster for these past years because I've been really optimistic, then really pessimistic, then really optimistic, et cetera, et cetera. Thank you very much.
Already have a question, so I'm going to give you my mic.
Yep. Thank you for a great presentation. On my personal observation, I kind of build up my humble opinion on what could be the three main directions of the addressing the clinical requirements, which are the kind of AI secretary, which reduce the burdens on the clinicians, so helps him, her to work faster. So the more experienced clinicians can work faster. The second one is kind of AI assistance, which observes what happens and mitigates the human's error, which can happen, so kind of makes an alert. And the third one, the most experienced kind of AI expert, which helps with the decisions. And let's say we can choose only one way, and apparently each way can address kind of the problems on different markets. Some markets really need to address the underemployment. Some markets just really need to help the already experienced clinicians. What way would you choose? What's your opinion on this?
Okay, so I only have one Christmas present. Okay, I have to choose. I'm like my kids. No. My answer will actually be it depends where you're working. To be honest, if you ask me, Laure Fournier, like personally, I would love the AI secretary because I don't mind doing my job as a radiologist, but it's really just a bit of a pain to do all the secretarial work that goes, like all the extra little things, right? But that's probably because I work in an academic hospital, I have a certain radiological expertise, etc. Maybe if I was a radiologist working in private practice, very isolated, I would rather have an AI assistant that is either alerting me or helping me out. So yeah, I'm not sure that it's that easy to choose because the answers will be different. But there are things that are easier to develop, and it's a lot less risky to develop an AI secretary. I mean, I'm just thinking industry-wise, right? You're not taking much risk because there are no, hard decisions that are going to be made on that. And so you have a lot less hoops to go over. So if I was putting my money on something, if I was investing in a company, I would invest on a company that was working on a secretary.
George?
Yeah, one of your slides that you had that you kind of just glossed over really quickly, but I really enjoyed it, was when you were talking about being unfair with AI. And I think that's something that is really appropriate, because then a couple of slides later, you also talk about cost, and you want it to be cheap. So not only we're putting a lot of burden on the evidence, and we want it to be fully integrated, but at the same time, we want it to be very cheap. So if we use the analogy, for example, of drug development, where people are willing to pay thousands of pounds or euros for drugs, we're not willing to pay that much for AI. And then we enter in this kind of chicken and egg problem where, unless these systems are deployed in the real world, we cannot gather the evidence, and thus we cannot even justify the healthcare economic assessment for many of these tools. So what is your opinion when it comes to that unfairness? Should we be striving for perfection, or should we be accepting that there should be some degree of imperfection so that we can actually gather the evidence, similarly to what we do in medicines?
Okay, that's a bit of a tough question, but yes, no, definitely the economics of it, and I just like at the end said the economics is a problem, but it is a big, big issue, because as you were saying, at least in a drug, you know, they'll sell thousands of euros and they'll recover their costs. The thing is, when you give a treatment to a patient, the benefit to the patient is directly accessible and directly attributed to that treatment. When you're doing diagnostic, the benefit is very downstream, right? So it's hard to demonstrate that. My answer to your choice is that it's not the right choice. You guys just have to get better at this. I think that's why we have to go toward, I believe, but this is really my opinion, that more general AIs might be more helpful. Things that can answer lots of questions at once, maybe not perfectly, but where, you know, we sort of take them in hand and understand them. But to be honest, I always swore that I would not predict what was going to go on, because I think things are moving so fast. I'm not even sure that what this talk will make any sense in 5 years. There might be such new solutions that are coming out there, things that will be solving the little problems, and I haven't imagined it yet. So I'm sorry, I'm not really answering your question. I think we're not at that level of maturity, actually, honestly.
Thank you for your inspiring talk. You talked about what is already used in clinical practice, and I was wondering what you have personally used or is used in your clinic at the moment from an AI standpoint.
So at the moment, nothing. Well, no, actually, fracture detection. The two examples I gave, I think, are present in, I mean, I couldn't give you a percentage. I haven't done that. I haven't checked or anything, but let's just say off the top of my head, 75% of private practice and maybe 100% for breast mammography, honestly. But also these systems, at least for breast mammography, often are sold with the mammograph, like the machine, right? So that's, just to go back to the economics of it, that's one way to solve the cost problem. In academic hospitals, first of all, we're a tertiary center for breast imaging, and we just have such complicated cases that the AI systems are not useful, so we do not use them. But this is like really an expert center. That's also why I was answering, I forget who, by saying our needs are so different. Our needs are very different between a private practice non-expert and an expert, right? So the only thing we have is bone fracture. We have it because it's given to us for free. I'm not completely sure that we would buy it. Sorry, guys, if you're in here.
Hello. Thank you for the interesting presentation. I am going to play the devil's advocate with my question. So we all know about medical doctor's errors. That's why a patient would go to a second AV or a third AV if the first primary diagnosis, he didn't really like it. And so my question is, why would you consider a neural networks or a machine learning wrong output as a radiologist's nightmare when the exact same error could be done by a junior patient? or junior radiologist? And if the answer is that the decisions are made collectively, because a junior would always go to the supervisor, then wouldn't that be the same as an AI algorithm making a mistake and then a supervisor actually fine-tuning and dynamically learning or teaching the AI algorithm as they go? And thank you.
Yeah, no, you're completely right. Doctors make mistakes, and that's obvious and true, and it happens every day, unfortunately. It's not purposely. Well, I mean, it's a multi-tiered answer, but yes, you're right. If AI is supervised by human, I mean, that's the whole point of having the AI supervised by human, right? But for that, the human has to be expert enough to know, right? But as you were saying, all human radiologists are not experts, and there are mistakes that are made. Maybe one argument is that a human will never take a cat for a toaster. But this has not been proved. Intuitively, people think that the medical errors are maybe more marginal or smaller errors than what an AI is capable of. But to be honest, it might not be totally true. It might not be totally true. The only thing is that today we pay, wait, let me say it this way. I'm going to give the bone fracture example. One of my colleagues calculated that if they bought that system for bone fracture detection, it would cost as much as the salary of a resident per year. But the thing is, the resident doesn't just look at the bone fracture, right? The resident does a lot of other things. The resident makes mistakes, the AI makes mistakes, but in the end, the resident does a lot of things. And that's where the cost issue comes, you know? It's not so much that AI is not useful, it is, but it has to be so useful that it's really worth that investment, you know? And that's the thing. It's right now, the price that it would represent for a department is quite high. I don't know, I mean, it sort of only half answers your question, but.
Two questions left, so here and there, and then we will have to stop. Go for it.
Thank you for the great presentation. Could you elaborate on how economic considerations of radiology practices specifically affect in a way that they might impede or facilitate adoption of AI, and also to what extent those economic or budgetary considerations of radiology practices align with well-being of patients, and maybe sort of a global perspective if you have it.
So I sort of half answered that with my resident comment. So it sounds like us radiologists are really cheap and we don't want to pay for the patient to be well diagnosed. Yeah, it's really a lot of benefit cost effectiveness, right? It's all about that. It's how many times does the AI impact positively your diagnosis versus how much you're spending for it. And just to give you an example, we did a study on pulmonary embolism, and we looked over 100 or 200 cases, I can't remember, this was a while ago, and it impacted our diagnosis once. So, I mean, unfortunately, we are working in a limited budget, and we have to choose where we put our money. And as I was saying, AI has to have a strong impact on either diagnostic performance or workload or time or something for it to become enough to justify that cost. And it's just a reality. And I was saying that I guess bone fracture and mammograms are two different examples, because the breast mammography, often that AI system comes with the machine, so with the device, so it's kind of incorporated in the global cost, and so you just have that investment to buy the device and you get the whole package, right? Whereas bone fracture, you'd have to buy it specifically for that, but maybe the volume in a clinical practice, the volume of radiographies that it would represent would make it worth it, because if the radiologist goes faster, then he's going to read more. more x-rays, right? So it's really a case-by-case question of this cost effectiveness, right? And I guess the answer is that today we don't really know how to evaluate that. And we're not doing a good job at it, but as someone was saying, how do we fund these clinical trials, you know? So in France, there is specific funding for that. There are calls out there to demonstrate the cost effectiveness, but then you get that super complicated workflow I was showing. So it's something we have to work on. And then maybe the last thing I like to say is that I strongly believe in the wow effect, you know? Like when you download an app on your phone, I forget what the statistics is, but if you haven't used it in the first month, then you're never going to use it. It's sort of the same with our AI applications, right? I mean, if we use it and then if you take it away, people don't notice, then you're not answering their need, right? And all of that will come into account when you're balancing where you want to put your money.
Thank you. Thank you for that great talk. I have a question about randomized control trials. What's your opinion about it? When do we need randomized control trials to test our models? And also, how should we do it? Because when I look at the studies, I feel like when they test an AI software, they usually are like semi-automatic, which means you have the combination of an AI tool with the radiologist. And when you look at the software, you see, okay, the AI is just performing some small task, like segmentation tasks. And then I feel like it's not a fair comparison to say, okay, this was a randomized control trial about the AI tool. It was more like the whole software framework.
Sorry, I didn't hear the beginning of your question.
It was, when do we need randomized control trials? And when we don't need it? What's your opinion about it?
When do we need them? Well, I guess the regulatory structures will tell you always. Theoretically, it's like the perfect study to evaluate something. I think, well, yeah, I think it is important because you have to compare, right? You have to compare what am I doing when I have it, what am I doing when I'm not. I don't really see how we can get out of that situation. And then you were saying something about it being unfair to the AI because I didn't get why you were saying.
The software tools with AI, you see that only a small part of this software is AI driven. So you only have like a small segmentation part from the AI tool. But if you test the software in a randomized control trial, you also test like the radiologist who is using this tool, right?
No, of course, yes, you are testing the radiologist, and what you're saying is if the radiologist is not that great, then the AI can't help them that much. Yes, that's true, but I mean, what we're wondering is it going to help the radiologist? So we have to, you know, test the radiologist at the same time, and that's why you have the radiologist without AI. I mean, when you have that controlled trial, you're supposed to have the radiologist without AI. So theoretically, you're taking out the impact of the human in your comparison, right? But of course it will, I mean, just the way they use it, if they're familiar with it, all of that, of course, will impact. But it's kind of funny that you say that, because in the radiology community, we consider that usually the radiologists are treated unfairly in the comparisons, so.
Thank you.
Well, let's thank Laure again for her presentation. Okay, so now we move on to the next all session on geometric deep learning and federated learning.
All right. After this great keynote, we're moving on to the second oral session of the day. Good afternoon, everyone. I'm Loïc Lefolgoc from Télécom Paris, France.
I'm Tolga Taşzen from the University of Utah. The first talk will be given by Simon Dahan from King's College London, and the talk is titled Multi-Scale Surface Vision Transformer.
Hello. Good afternoon, good afternoon, everyone. My name is Simon Dao. I'm going to try to follow after this great keynote. I'm a final year PhD student at King's College London, and I will start this afternoon session with the presentation of our paper, the Multi-Scale Surface Vision Transformer, or MSSIT for short. So the MSSIT is a general purpose deep learning architecture adapting transformer-based models for cortical surface learning. So in the first slides of this presentation, I'm going to try to motivate a bit the reason why we have been developing this model and the interest in general of developing deep learning model to study the surface of the brain. So what is the cortex? The cortex is the outermost layer of the brain made of gray matter tissues and composed of billions of neurons. So its anatomical complexity and specialized regions are essential for understanding cognition, brain organization, and neurological disorders. Surfaces are a favorite domain for representing cortical data, and surface representation of cortical data offers several advantages over 3D volumes. First, surfaces preserve the topological continuity and accuracy of cortical representation. So here the orange line, for instance, is the actual topographic distance between the region 1 and 6V, as the red line is the Euclidean distance between the two, which is much shorter. And secondly, more on the application side, surfaces also offer better alignment between subjects and a better representation of individual variability. Here I'm showing cortical parcellations into functional regions from the HCP dataset. And these three subjects show distinct regional characteristics in the frontal eye field that cannot be obtained, that can only be obtained via surface registration. So we understand that the cortical data is better represented on the surface. Unfortunately, using deep learning directly on the cortical surface is not easy. It comes from the fact that surface data is by nature non-Euclidean, and therefore the classical tools that we have for CNNs for images, for instance, they cannot be translated directly to study the surface. So some methods have been developed over the years, such as surface convolutions, where you try, for instance, to learn hexagonal filters on a mesh, but these methods, for instance, don't build rotational equivariance properties, and therefore they are not robust to misalignment between surfaces. There are also spectral CNNs that learns filters in the form of spherical harmonics, but these ones are quite computationally costly. Therefore, to solve some of these issues and to build a more flexible and general framework for surface deep learning, we introduced at MIDL in 2022 the surface vision transformer for surface analysis with vision transformers. And this method circumvented the need for convolutions by translating surface analysis to a sequence-to-sequence learning problem and using vision transformer. So in short, how it worked is that cortical data that is represented on a mesh is projected from its native resolution to a sphericalized mesh, typically a 6-order icosphere tessellation. And then, in order to regularly patch the surface, we impose on that sphere an icospheric grid of lower resolution, so typically an ICO2 grid, to extract a set of non-overlapping triangular patches. These patches will form a sequence of tokens that can then be used as for any vision transformer as a sequence and use it as any vision transformer, so with positional embeddings, and then a set of multi-head self-attention layers, and finally for classification or regression tasks. However, the SIT, the surface vision transformer, showed to outperform a lot of geometric deep learning framework by modeling long-range dependencies. Also, it was quite robust to surface transformation and rotation, so not necessarily needed to have registered data to work. However, there were some limitations. First, the quadratic complexity of the self-attention operation limited the size of the surface patches that we extracted. And because of that limited patch resolution, the architecture was not made for dense prediction tasks, such as cortical parcellation. So as I was just explaining, one of the main limitations of the original SIT is that we had to impose a grid of low resolution on top of our ICO6 mesh. So here an ICO2, which gives us 300 patches of each 153 vertices. Actually, the SIT works quite well up until ICO3 grid sampling, but then it starts to decline. And here, the MSSIT that we are introducing is modeling the cortical patches with ICO5 resolution, which is the maximum resolution that we can have and can model actually very fine grain details. So to build the MSSIT, we took inspiration from the Swin transformers, which adapt vision transformer to process high-resolution images for dense prediction tasks. So it starts very similarly to the SIT. So you have your native mesh that is projected onto a spherical representation, so typically an ICO6. But then you patch your ICO6 with an ICO5 grid, which gives you a sequence of 20,000 tokens. So these tokens are projected, and then you have a set of MSSIT blocks that work at different sequence resolution and different sequence length before a final projection head. So in short, each MSSIT block is composed of one linear embedding layer that projects the embeddings to a dimension G that is doubled at every level. Then you have a local attention layers, a set of local attention layers, so it depends on the block, so you can have 2 or more. And finally, in each block, you have a patch merging operation that reduces the length of the sequence of tokens in your sequence representation. So the MSSIT introduces actually 2 main concepts, so the hierarchical modeling via patch merging and token representation, and a window and shifted window self-attention. So I'm going to try to describe those key concepts now. So first, the patch merging is maybe the simplest. So it's the blue layer that is represented here. So at any layer in the architecture, the tokens that corresponds to the 4 neighboring patches are grouped together to form a single token representation. So this is how we merge tokens from one block to the other. And by doing that, we reduce the sequence length across the MSSIT blocks by 4 at each level. By doing so, we produce a hierarchical representation of patch features that started from 20,000 tokens in our sequence, then to 5,000, 1,000, and then 320. However, the important difference with the SIT is not only that, is also the fact that we are using a self-attention mechanism that is not applied globally to the entire mesh, because with 20,000 patches, it's not really feasible on regular GPUs. But we use a form of local attention where the self-attention is applied within local windows. And only in the last level, so the level 4, the self-attention is applied to the entire mesh. So as I was saying, the self-attention is applied locally. So this is what we call the window multi-head self-attention. So for instance, here as an illustration, we would have the self-attention mechanism applied only between the tokens that make that triangle, so only the yellow triangles. And if you have a neighboring local windows, like the blue, the patches from the yellow and the blue local windows, they won't be computed all together with the self-attention. So this is the standard window self-attention, and with that, alternatively, we also have a shifted window self-attentions. The way it works is simply by shifting the local windows such that patches that were not previously in a certain local window are now present and can be computed with self-attention. By doing that, we introduce cross-window connections that preserve the cost of local attention. while increasing the model representations because we are sharing information between regions of the brain that were not linked before. Okay, so after having explained a bit the architecture, now we demonstrated how this architecture works on two sets of experiments. So the first is the phenotyping prediction using the DHCP dataset. So we use cortical metrics derived from MRI scans from the DHCP dataset. So about almost 600 neonatal subjects. Some are term babies, so they were born after 37 weeks of gestation. Some are preterm babies, born before 37 weeks. And the data is available in two configurations, so what we call template and native. Templates mean registered data altogether, so the surfaces are registered altogether, and the native, they are unregistered. And the two tasks that we use to demonstrate the capabilities of the model are the PMA task, so post-menstrual age at scan. So essentially trying to find the age at which the scan was taken for a baby, and the gestational age at birth, GA, which is the age at which the baby was born from a scan that was taken at term equivalent age. So here I'm comparing the results between two geometric deep learning models, spherical UNet and MONET, with three versions of the surface transformer I was telling you before, the SRT, at different resolution. And I'm comparing that with the MSSIT, either with shifted attention or without shifted attention. So for the PME task, which is the simplest task, so the MSSIT is performing best with some margin with the SIT models. And there is not much difference between using actually the shifted attention without the shifted attention. However, for the GA task, which is the most complicated task because it somehow evaluates the prematurity of babies, we can see a huge difference between the MSSIT with shifted attention and the other methods. And the second interesting point is the fact that between template configuration and native configuration, so between training with only registered data and only unregistered data, we got kind of similar results, which shows some sort of robustness to transformation, while other geometric deep learning model, for instance, the spherical UNet, has a huge loss in accuracy, in mean absolute error between the two configurations. So I didn't say, but here I'm showing the mean absolute error average across 3 training runs, and the error bar is showing you the standard deviations between the errors between those runs. And one of the main advantages of the MSSIT is that the combination between the hierarchical representation and the local self-attentions allows actually to turn this architecture into a UNet-like model with upsampling layers and skip connections. So essentially, you can, here the 4 first layers are exactly the same one as I showed you before, and you can add 3 extra layers with skip connection and replace the patch merging that was in blue with a patch partition that is in pink, which is doing the reverse operation of essentially separating a huge patch, a triangular patch, into smaller patches. And by doing that, you can have actually a segmentation pipeline. So here, for instance, so you can reverse essentially the procedure to go from a NICO2 patch resolution at the bottleneck to NICO 5 and then project to your sphere in the same resolution. So here I'm showing you some results for cortical pacillation into 31 regions of the brain from the MindBoggle 101 data sets and the input features of the circle depth and curvature maps. So results demonstrated competitive results for the MSSIT with a nice DIE score, which was lower than MONET, which is another geometric deep learning model, but better than other methods. So just in conclusion, so the MSSIT is a general purpose deep learning backbone adapting the swing transform architecture for cortical surface learning. We introduce window self-attention, which is very computationally efficient. And the SIT does not compromise on filter expressivity, computational complexity, or transformation equivalence. Something I didn't mention is that here I'm showing you only examples with cortical data, but actually you can adapt this kind of framework to any biomedical surfaces as long as you can represent your data with a sequence of patches. Just a word on the fact that the code base is available. So the MSSIT code is available on our labs GitHub, Matrix Lab Surface Vision Transformers. You have multiple checkpoints with pre-trained model on UK Biobank, HCP, DHCP, and preprocessed DHCP data is also available. I put the links here, but please come and find me if you have questions about that. Thank you very much for your time. Don't hesitate to come for a chat. Codebase is available, as I was saying, and thank you to all my co-authors, my supervisors, Dr. Emma Robinson and Professor Daniel Rucker, and my colleague, Logan Williams. Thank you very much.
Thank you, Simon, for the very interesting talk. Questions from the audience?
Yeah. Yeah, so are you talking about the shifting window? Well, yeah. Okay, so there is actually, I think, room for improvement on that particular aspect. So the way I did it in the paper is I manually, it was a bit complex, but I manually try to order the patches so that they somehow like make some sort of sense. So that when I shift the local attentions, the patches that like the grid that is used for local attentions comes from like neighboring patches. So like patches that are close, like spatially, are going to be connected together. I guess there are more sophisticated way maybe to define these operations. It seems to be working quite well. Like when you don't use shifted attention and you use it, you see a difference. But yeah, that's definitely, I think, a room for improvement for other.
Yeah, there are many options.
Yeah.
Okay. Now it works. Thank you.
Other questions?
Hi. Yeah, very nice talk. I was wondering whether you may consider also comparing to point transformers. So in principle, you're using the neighborhood of your surface representation to define the set of points that interact within the self-attention in your transformer block. But I think in point clouds, if you have a neighborhood that is similar, so maybe this could be considered or compared.
Sorry, can you repeat again? Sorry, I didn't hear well.
Have you looked into point transformers, which work on a neighborhood on point clouds and also do transformer-based self-attention on the neighborhood of every single node or vertex in the graph?
That's a good point. Actually, I haven't. Yeah, I haven't. I only worked with that kind of meshes, like not with point clouds. That could be very interesting to look for that. Yeah. Sorry, don't have an answer for that.
One last question, if there's any.
Hi, thank you for the talk. So I was wondering what improvements in the performance did you find by including a layer that does global attention versus only local attention? So for example, if you used an analog of local attention that uses convolutions on these vertexes, would you have similar performance, or is the attention mechanism giving you something extra that the convolutions might not?
So the question was about differences between global and local attention?
Yes, so whether global attention really is required, or whether just local attention or equivalent convolution operations are enough for this kind of flexibility.
Yeah, so one of the motivation of using this kind of local attention is the computational cost of applying attention. So if you want to model really fine-grained details on the mesh, and you want to use like an ICO 5 resolution, so you have 20,000 patches, you can't, like, I mean, at least on the GPUs I'm using, I can't use global attention. So a way to compensate for that is to use this form of model, and actually you can tweak the parameters of the model so that you can, if for instance you can apply global attention not only in the last layer, but you can apply it also in the third and the fourth layer. So I think that can help actually to improve again the model. When I compared the results with the SIT, which use only global attention, like the MSSIT seems to improve the performance on all the tasks I've been testing. So I guess there is a point of using the local attention. Then compared to the convolutions, I guess the point of using transformers is to have less biases and inductive biases in the architecture. So potentially, I'm using very small data sets because surface data is quite rare, but imagine having like tens of thousands of data. You could actually scale a lot and improve a lot the performance, I would guess, compared to convolutions.
Thank you.
I think we need to move to the next speaker, so let's thank Simon again.
The second presentation is entitled Predicting Age-Related Macular Degeneration Progression from Retinal Optical Coherence Tomography with Intra-Subject Temporal Consistency. It will be presented by Arunava Chakravarti from Medical University of Vienna.
Good afternoon, everyone. I'm excited to present my work titled Predicting Age-Related Macular Degeneration Progression from Retinal Optical Coherence Tomography with Intra-Subject Consistency. So, age-related macular degeneration is an irreversible retinal disease which often progresses from an intermediate to late dry stage. And longitudinal optical coherence tomography images are routinely acquired across multiple visits to monitor AMD progression. So forecasting the future risk of AMD progression is crucial for patient-specific disease management and recruitment of high-risk patients in clinical trials. So given the current scan of an eye in the intermediate stage of AMD, we aim to address two related tasks. The first is to predict if the eye converts to the late dry AMD stage within the next T months. Here T can be any arbitrary continuous time point within the next 2 years. And the second task is to predict a scalar risk score R, which is inversely related to the time to conversion. So this risk score can be thresholded, and then the input scan can be stratified into different risk groups with respect to conversion. So the key challenges here are the lack of any reliable and clinically established biomarkers which can predict the future risk of conversion, large intersubject variability in the speed of AMD progression, class imbalance as we have very few converted DAMD stage samples, and missing labels due to non-conversion within the limited duration of the study, which is censoring. So existing methods can be broadly categorized into three groups. The first one is the discrete models, the semi-parametric continuous models, and recently neural OD-based methods have also been explored. So the discrete models, essentially you divide the future in time into discrete class bins for multi-class classification, and this leads to imprecise training labels, and it prevents prediction of conversion at arbitrary continuous time points. The semi-parametric models such as DeepServe and FastCPH, they have limited flexibility in capturing complex inter-subject variations. So this is because the predicted survival curves for all patients are constrained to be a scaled version of a single population level baseline curve. This problem is alleviated by neural ODs, which are non-parametric continuous time models, and they make no assumptions on the survival curve's shape. So recent applications include SORDEN, which was originally developed for tabular biomarkers, and in retinal image analysis, it has also been used to forecast diabetic retinopathy progression in fundus images and atrophy segmentation in OCT images. So in this work, we combine an IAMD versus DAMD stage classifier with a neural ODE for continuous time modeling of the cumulative distribution function of the conversion time. So additionally, we incorporate intra-subject consistency between the predictions from different visits of the same eye, and we also propose to use the logits of our AMD stage classifier as a risk score with the help of a temporal ranking loss. So the encoder projects the input scan ij to the corresponding feature fj, which is then fed through a linear stage classifier. which predicts if the current scan is in the intermediate or the late dry stage. Here Rj represents the logits, which is the signed distance of the feature Fj from the decision hyperplane. We use convex tiny model for our encoder and binary cross entropy as the classification loss. So since our aim is to forecast the AMD stage for a future time point, so we employ a neural ODE based approach. So the neural ODE models the trajectory of disease progression, and it predicts the future estimate for the feature from the current feature Fj itself. So this future feature F cap k is again fed through the same stage classifier as before with identical weights to predict the risk of conversion of the scan in the future time point key. So we also incorporate a longitudinal intra-subject consistency. So here the upper branch, as before, predicts the future feature F cap k from the current scan ij, and ideally this F cap k should be identical to the feature Fk in the lower branch, which is directly obtained from the actual future visit scan. So we consider training with pair of scans from the same eye during training, but the lower branch is not used at inference time, and you can use only the upper branch to predict the future risk of conversion from a single scan. So the AMD stage classifier itself has no additional constraints. It just ensures that your intermediate stage and late stage samples are on opposite sides of the decision hyperplane. So the risk score ranking is an additional feature regularizer on the intermediate samples, which says essentially that the classifier's logits, which is the signed distance from the decision hyperplane, is inversely related to the time to conversion. That is, a sample closer to the decision hyperplane would have a lower time to conversion and vice versa. So this can be achieved by constructing image pairs, IM-IN, across the training batch, which include both intra and inter-subject pairs. And we perform a logistic regression using the difference in the logits of the two images, Rm minus Rn, as input to predict which image is converting first. So the equation essentially shows that here Pm less than n represents the probability that Im converts before In, and we maximize this probability for those image pairs where this relation is true, that is Im actually converts before In, and for the other subset, it tries to minimize the log probability. So the neural ODE, as I said earlier, it models the disease progression trajectory in the feature embedding, starting from the feature Fj of the current scan, and it tries to predict the future feature Fk. So here in the diagram, Ft represents the feature at some intermediate time step between Fj and Fk, and as time progresses from t to dt to t plus dt, the feature is evolved or displaced by v times dt, where v represents the instantaneous velocity vector at that particular point Ft. So here V is modeled with a neural network which takes Ft as input, and the forward pass is performed with Euler's ODE solver to estimate the future feature Fk, and the back propagation is performed with adjoint sensitivity analysis as with any neural ODE, which requires a constant GPU memory independent of the time interval k minus j for which your ODE needs to be evolved. So we model V with a GRU ODE architecture's extension. So the GRU ODE is a continuous time extension of the recurrent GRU models. And what we did was to essentially stack 3 such layers with 2 12 parallel heads. The original one used a single layer with single head. So in the left side diagram, we see that our feature embedding acts as the hidden state for all the layers. And additionally, the outputs from each multi-head GRU ODE V acts as additional external inputs to all the subsequent layers. So in each of these blocks, F and V are first projected to a lower dimensional space with fully connected layers fed through GRU ODE regular cells, and their outputs from the different heads are concatenated, and again a fully connected layer is applied to obtain the final output from each block. We evaluated our method on 3,534 OCT scans from 235 eyes, out of which 40 were converters. So these were collected in-house at the Department of Ophthalmology at Medical University of Vienna. We performed a 5-fold cross-validation and report the area under the ROC curves for the conversion prediction task. So although our method can predict the conversion at arbitrarily continuous time points, we chose to report on these 6, 12, 18, and 24-month time intervals. We also report the concordance index, which measures the effectiveness of our ranking loss, so that we can use our logits as a risk to arrange the scans in decreasing order of their conversion time. We compared our method against several popular strategies, such as discrete classification-based methods, semi-continuous methods, and existing ODE-based method. And our method outperformed them both in terms of the AUROC and the concordance index. In terms of ablation, we added each of our proposed loss terms one at a time, row-wise. And if you look at the concordance index, each of these additions led to consistent improvement in performance, showing that all the loss terms actually have some utility. Similar improvement in performance is also seen for the EUROC for 12 and 18-month time intervals, but with some minor deviations at 6 and the 24-month. So the logits from the classifier, we have a post-processing step where we calibrate it on the validation set to map it to the range of 0 to 1 so that we can use it as a risk score. And on the test samples, we compute these normalized risk scores and threshold them to divide your population into low, medium, and high risk groups. If we plot the population level survival curves, the Kaplan-Meier curves, we see a clear separation between the survival curves of all these 3 risk groups, which shows the efficacy of our proposed risk score. Here, the high-risk group shown in red shows a drastic drop in their survival probabilities as compared to the other 2 groups. We also performed a UMAP-based feature visualization. Here, the gray dots represent those scans from eyes which did not convert during the entire duration of the study, so they are censored. The red dots are scans with high risk, which are going to convert soon. And the blue dots represent scans which are low risk and have a long time to conversion. So overall, the method learns a smooth manifold, and the red dots are mostly concentrated on the right side, and the low risk ones mostly towards the left-hand side of the learned feature manifold. So these are some GradCam-based attribution maps. And broadly speaking, most of them tend to focus on irregular regions around the retinal pigment epithelium, which is this bright looking layer. And clinically, RP is the region which is most affected by the age-related macular degeneration. To summarize, predicting DMD onset is challenging due to wide intersubject variability and lack of reliable biomarkers. We combine AMD stage classifier with the neural ODE for continuous time modeling of time to conversion. The intra-subject consistency and the risk score ranking losses are useful feature regularizers, which enable us to learn semantically meaningful manifolds. And we predict the risk score to stratify eyes into low and high risk groups for conversion. This has the potential to facilitate personalized treatment and help in clinical trial recruitment. Thank you for your attention, and I'm open to questions.
Presentation, we have time for questions.
Okay, thank you. As I'm not very familiar with the neural ODE, and can you turn to the teaser page? No, the previous. The lost computer. Yeah, this page. Does this mean, for example, the first line is the images at time step j, and the bottom is at time step k, and so we need to repeat the stacked multi-head GRU ODE for k minus j steps?
Like, I did not get the question, but I'll kind of summarize it once more. So the idea is the lower branch is some sort of a, you can think of it as a teacher model. So where you actually have the future visit, and you actually use your encoder to get the actual kind of a ground truth feature what you would have if you had access to the future visit. And the top branch is essentially, since you don't have the future visit, you are trying to, it's like a recurrent network but in continuous time, which is trying to predict the future feature. So fcap k should ideally be the same as fk. So there is a mean squared error between them. And as well as if you look at the conversion probabilities, so at the end, so pcap k and pk between the two branches should also be consistent with each other. So there is a binary cross entropy loss.
Yeah. So I'm curious about what if we use the ODE to change the IK one step further and compute the difference between the IK plus 1 and the feature of the the top line. Maybe if we both push the top line and the bottom line for one further step, use the ODE, will this loss be consistent?
I did not get the question. Maybe we can discuss it offline.
Okay. Thank you.
Questions?
Thank you for the presentation. I was just wondering about the weighting of the different losses.
Yes.
As some of these terms seem to be, I guess, they drive more your task than others.
So in this work, I finally, like the results I showed are like these lost weights were dynamically adapted with the multitask Adam optimizer. But essentially, I do have some extra slides. Yeah, so I tried different different ways. So if you can weigh them equally, I tried handcrafted weights, but it's difficult because like if you want to perform a grid search on 5-fold cross validation, it becomes difficult. So these are more like scaling the losses to a similar range. So it's handcrafted in that sense. The one which I showed, which is multitask Adam, and there is another way of dynamically tuning your weights without really specifying them, which is uncertainty weighting. So if you look, there is not a huge variation in terms of the performance. So I won't say that it's a super critical thing related to this work, but overall MT Adam did seem to perform slightly better. Yeah.
In the interest of time, we're going to move on to the next presentation. So let's thank the speaker again.
Next talk is titled Fluid RegNet, Longitudinal Registration of Retinal OCT Images with New Pathological Fluids. And the talk will be given by Julia Andresen from the University of Lübeck.
Hi, hello everyone, and thank you for the introduction. As said, I'm Julia Andresen, and I'm going to present Fluid RegNet, which is short for Fluid Registration Network. I'm not going to read the title again, but I would like to highlight already that we are working with images that show new developing pathologies here. To motivate our work, I would like to show you a retinal disorder, which is called central serous chorioretinopathy. And what is special about it is that it mainly affects young individuals, so most of them are in their 30s or 40s, and it can lead to severe loss of vision. So especially for those young persons, one is obviously very interested in treating this disease accordingly and then monitoring it over time. So since we've seen optical coherence tomography images in the previous talk, I would like to go directly to show you how those images look like for CSCR. So here we have a timeline for one patient over approximately 2 years. And as you can see, this disease fluctuates quite a lot. So we have a lot of subretinal fluids that form. These are these dark areas in the images. That is some fluids that enter below the retina and lift up the retinal tissue and afterwards. So for monitoring, one might be interested now in performing different tasks like volume change assessments. So one might be interested how the volume of different pathologies changed, or also of the retinal tissue. And also localization might be important, where we are looking for structures we observed in one time point and want to find it in the next time point again. So this is obviously quite difficult, since we are observing severe differences between the images, both in shape and in appearance. So normally, our solution would be to use image registration, since this allows us to perform volume change assessments, and also the localization will be possible directly with the deformation fields that result from the registration. But since we are dealing with a disease that changes so much, we encounter a lot of missing correspondences between time points. So running standard image registration frameworks will simply not give good results here. So if you have a result on this example, we have a moving image with no subretinal fluid and a fixed image where a new subretinal fluid formed. And if we then run an image registration framework on these images, the result will look something like this here. So you can see that the upper border of the retina gets mapped quite nicely. But inside the retina, you can see that we can observe very unrealistic deformations. The retinal layers are stretched somehow to match this new fluid that formed, but there's no way that we can depict it appropriately. And this is why these deformation fields cannot be used for monitoring here. We cannot perform volume change assessments simply because the retinal layers are not changed in volume at the right places. And also localization is not possible simply because this deformation field is so implausible here. So what we need are realistic deformation fields, and this was the goal of our work where FluidRegNet comes into place. And as I already stated, the main problem for registering these OCT images is that we cannot insert missing structures using a deformation field alone. So the idea here is that if we are having a moving image with no fluid and a fixed image where a new fluid developed, we insert a small fluid seed, so to say. So we are changing a very small area of our image. We are changing the intensities in a small subset of our image, and we only then perform the image registration, so that we then extend the inserted fluid to the volume we can observe in the fixed image. And to teaser how the results look like with our network, these are real examples here. So here we have the moving image without SRF and the fixed image with a subretinal fluid. And these are the outputs our network predicts. So the network learns to both localize those fluid seeds and also to extend them to the volume we need to make those images look similar in the end. How do we achieve this? The network is unit-based, so the architecture is basically the same except for the separate input blocks and the separate output blocks. The inputs are the moving and the fixed images, as well as the difference image between those two, and the outputs are then the appearance offset map and the deformation field. This is achieved using a 3-step training approach. So in the first step, we are pre-training the backbone of our network and the deformation block only. So in the end, the first step of training is a standard registration network. The second step consists of training only the appearance output block. And finally, we are then training the entire network. And this 3-step training helps us to disentangle this complicated interaction between the deformation and the appearance offsets. Some more details about the training objectives. So as always in image registration, we are looking at an image distance measure and also a regularizer. And what is coming on top of this is the sparsity loss here in the end. So for the image distance, we are using the normalized cross-correlation, and we compare the moving image that has been appearance adapted and deformed with the fixed image. The regularization is a bit more complicated in this case because our goal is that the deformation field behaves differently for fluid regions and for the normal retinal tissue, which is why we are using a masked diffusion regularizer. That is, we are regularizing the deformation field only outside of fluid regions. And to do so, we are not using any manual labels, but we are automatically generating rough fluid masks that are then used for performing this masked regularization. We also want that our deformation field is somehow plausible also in the fluid regions. That is why we are introducing a second regularizer, which is a penalty on negative values of our Jacobian determinant of the deformation field. And finally, we want to ensure that the overall image tissue gets mapped correctly, which is why we are introducing a weak supervision using the segmentations of the retina of our two images. The last loss term is the sparsity loss, and this is basically only to ensure that the appearance offsets we are introducing are small. We do not want to in-paint the whole fluid or so this is why we need to ensure that these appearance offset are introduced only in the fewest pixels possible. So some last words about our methods. We are using an OCT data set that consists of 369 volumetric spectralis OCT images from 61 eyes of 32 CSCR patients, 33 CSCR patients, and this results in approximately 4,200 2D image registration pairs. And I would like to mention here that the data we are using has been acquired during clinical routine, so this is real-world data that we are using. To now come to our experiments, so in the first test we tried to evaluate how good our network is in registration itself. So to do so, we registered each image to its subsequent follow-up, and we compare performance here to voxelmorph as well as ANSYN. And I would like to start off with an exemplar result. So here on the bottom we have the moving image, and on top the fixed image. And there you can see that quite a lot of new fluids appeared during those 2 time points. And if we have a look at the results generated by voxelmorph, we can see that in this case we have an overly smooth deformation field, which results in basically no registration taking place here. So the upper border of the retina, the inner limiting membrane, simply gets not mapped in this case. For ZIN, we can observe kind of the opposite behavior. So the inner limiting membrane gets mapped quite nicely, but at the cost of a very unrealistic deformation field where we can see a lot of foldings inside the retinal layers, which is not the behavior that we would expect in real eyes. And finally, the results of our network here, we can see the most realistic deformation field, where we can see a large volume increase in those areas where new fluids appear. And consequently, the normal retinal tissue is displaced instead of being changed in volume, which is what we would observe in the real retina as well. And these results are also visible in the quantitative evaluation. Here we can see that regarding the alignment of the inner limiting membrane, we are somewhere in between the other 2 methods, but regarding the realism and the regularity of our deformation fields, we can perform much better. So we see very few inversions in our deformation field, and the volume change focuses here on the area where we can observe pathologies. In a second experiment, we used the outputs of our network to perform an unsupervised segmentation of new fluids. And to do so, we perform simple thresholding on the outputs of our network, where we use the deformed appearance offsets and the Jacobian determinant of the deformation field. How this looks like, again in a short example here. So here we have a moving image with no subretinal fluid and a fixed image where a new fluid formed. And if you have a look at the outputs of our network down here, you can already imagine that thresholding will give us quite nice segmentations of the new fluid. And this can also be seen in the binary segmentations that result from the thresholding. We compared this to 2 unsupervised anomaly detection methods, namely NSA and fast anogan. And here we compared both the detection rates of our method and the dye score of the fluids that have been detected. And here we can observe that regarding detection, we are somewhere in between those other 2 methods. But with the dye score, we can perform much better here. So the delineation of those fluids that have been detected is much better for this registration-based framework. So let me come to the outlook here. So what we are doing currently is we are using FluidRegNet not for the intra-patient longitudinal registration, but for the inter-patient registration of healthy to diseased images. And we then perform again this thresholding on the outputs. And yeah, these are preliminary results of our anomaly detection here. So you can see that the pathologies we've been interested in get delineated quite nicely. And also we are now able to detect more subtle changes of the retina, like this darker intensities here in this photoreceptor layer, which can also be detected by our framework now. This brings me to the conclusion. I presented FluidRegNet, which is a registration network that allows us the longitudinal registration of OCT images with new pathologies that lead to large differences both in shape and in appearance of the considered images. We do so by using a sparse appearance seed that models the onset of fluid formation and the subsequent expansion of these fluids. We do not need any manual labels for training, so here we can perform, or we do not need this heavy load, working load that has to be done manually for other works. And also we can achieve plausible deformation fields that are fluid aware, and this directly allows us to apply this framework for the visualization and also the quantification of areas in the eye that have changed through over time. And finally, as I showed you, we can do unsupervised detection and segmentation of pathologies with this framework. So this brings me to the end of my talk. Thank you for listening. If you would like to download the paper, you can do so via the QR code, and I'm happy to answer questions. Thank you.
Thank you, Julia, for the very nice talk. Questions from the audience?
Hi, thank you very much for the talk. It was great. You touched on it at the beginning, but I just was wondering if you could elaborate a bit more on how exactly you go about creating and inserting the fluid seeds. And is it like, will you create just one seed or multiple seeds?
Well, let me go back to it. Here probably. So the network completely automatically learns where to place those seeds and also how many. So it's all on the loss function, how it's, like the compromise between image similarity and sparsity of the appearance map.
Thank you.
Hi, thank you for the talk. Very, very interesting work. I was just wondering, actually related to this, how much is your performance sort of dependent on the sparsity loss weighting? Because I was wondering how much would the network put the seeding here just to match the appearance, and compared to how much will be put the seeding first and then register to match the appearance?
So I didn't hear everything quite well, but I assume it's about the weighting of the different
so I was wondering if, this is how it works, okay.
It's quite sensitive to the weighting, which is why we introduced this three-step training to first get good deformation somehow and then introduce the appearance offset maps only, because then it helps to get a better disentanglement somehow. It's to make it less sensitive to weighting.
Okay, if I may ask a follow-up on that. So when you evaluate, for example, how much deformation, how much liquid, how much fluid was added, let's say, through the deformation estimation, do you combine that with the amount of appearance you added in the first place to estimate how much fluid you that was increased in total? Like how much was the change in volume due to the initial seeding? How much was that due to the, how much that is you can estimate from the deformation?
Okay. No, we didn't explicitly have a look at this. Would be interesting, yeah.
Thank you.
Maybe I'll ask one last question, if there's no. Okay, so I was wondering, in the kind of the spirit of the keynote and real-world applications, since you're following up these patients for many years, I'm assuming, have you considered what would happen if, like, the device in the clinic changes, different vendors, device starts being used? I noticed you're using normalized cross correlation as your metric. Would your method generalize to those scenarios? What can you do to make it generalize, I guess?
Well, I guess if it's just changing slightly, it should work still. But if we have really completely differently looking images, I would guess that we need to fine-tune somehow a bit on the new data we get. Yeah.
Thank you. Right, let's thank the speaker again.
Right, the last presentation is entitled Accelerating Physics-Informed Neural Fields for Fast-CT Perfusion Analysis in Acute Ischemic Stroke. Presented by Luca de Vries from University of Amsterdam.
All right, I'm excited to be here and to present our work about accelerating physics-informed neural fields for fast CT perfusion analysis in acute ischemic stroke. Now, CT perfusion is a spatial temporal imaging modality. It's captured during the administration of a contrast agent which is flowing through the brain. And its primary goal is to assess the location and the size of the infarct that the patient is suffering. Now, it's a spatial temporal imaging modality. It has a temporal resolution of about 1 to 3 seconds. And as you can see in the blue curve, it can be quite noisy, especially in regions of tissue. So because it's volumetric and spatial temporal, it makes it quite impossible for a radiologist to directly interpret these images. So the goal of CT perfusion analysis is to transform this spatial temporal imaging modality to a series of perfusion maps that depict something about the blood flow, the transit time, or the delay, for example, in the brain. And for each voxel, this is done relative to a global arterial input function, which is often selected in one of the main supplying arteries in the brain. Now, to find these perfusion parameters, we need to solve the inverse problem of a differential equation. And in this differential equation, we have terms for the contrast attenuation in a particular voxel. We have a term for the arterial input function, but also these terms for the perfusion parameters, which we aim to find. Now, to find them, we need to write this equation into residual form. And this is essentially nothing more than the difference between our theoretical model and the data that we observe. And we can use an arbitrary optimizer to kind of minimize this equation to find these parameters. But since these curves are noisy and the temporal resolution is low, that means also that this derivative with respect to time is not really well defined. And this also makes solving this problem not really straightforward. So we use physics-informed learning to approach this problem, because it has been shown that physics-informed learning works really well when data is scarce or noisy. And in particular, we use neural fields. And a field in physics is nothing more than a quantity, a scalar quantity or a vector quantity defined over a domain. That domain could be, for example, the Earth, and the field could be the temperature field on Earth. A neural field is a field parameterized by a neural network. So it's a neural representation of a field. So we can learn a neural network to estimate the temperature on the basis of a pair of coordinates. Now, we can also represent an image as a field of pixels, which are living on the spatial domain. And the quantity then is the RGB value for each of the pixels, for example. Now, we have CT perfusion imaging. And as you can imagine, we have a spatial temporal domain. And the Hounsfield unit will be the quantity that the neural field would be representing. So starting from the same differential equation, we can extend this differential equation to fields instead of just working on voxels. We include this spatial coordinate and then also write it in residual form. But instead of minimizing this equation, we now swap the fields for neural fields. So we learn an approximation to the data, and that will be the neural field for the tissue attenuation. And the same holds for the arterial input function. But also for the perfusion parameters. We learn neural fields as a surrogate for the real field. Now, we do not only need to minimize this residual loss, but we also need to minimize the two data losses to make sure that these neural fields are actually a proper fit to the data. So in summary, we have spatial temporal imaging data, and we select a global arterial input function, and then we learn a neural field to estimate this arterial input function. We do the same for the tissue attenuation data. On the basis of spatial temporal coordinates, we aim to estimate the Hounsfield unit at each of the voxel locations. And then we learn a third neural field for the perfusion parameters. And these three neural fields come together in this differential equation. And by minimizing all of these loss terms, we obtain the perfusion parameters. So when all of these models have converged, we can sample the neural field at an arbitrary resolution to obtain the perfusion maps. And from these three maps, we can calculate two more, which are also of interest to the radiologist. So with this approach, we can get more accurate perfusion parameters than commercially available software. And this is also more robust to noise. But scaling up this approach, this naive implementation of this approach for clinical applications is not really feasible. This is mostly because this method works really well, but it operates on slices as opposed to full volumes. The compute time, to be honest, is terribly slow, with about 40 minutes for a full volume to be computed. And we merely calculate the perfusion maps, but we do not do this follow-up task or this downstream task of infarct core segmentation. So in this work, we address these three issues. So we were not able to fit the volumetric spatial temporal data with the neural fields that we're using by simply using the coordinates as an input to these neural fields. So even with larger neural architectures or architectures with different activation functions, for example, we were not able to fit the high frequency details. So we solved this by using an encoding for the coordinates. And in particular, we use multi-resolution hash grid encoding. So with multi-resolution hash grid encoding, we can split an image up into multiple resolutions. In this example, 2 resolutions. And at each of these grid points, we have 2 learnable weights, which we can access through a hash table. Then when we sample a new coordinate, we can find the closest grid points for each of the resolutions and do a linear interpolation between these weights at these grid points to generate this embedding E. So we share this embedding layer between the spatial coordinates of the tissue attenuation network and the neural field for the perfusion parameters. So this already speeds up optimization quite a bit, but as you can imagine, it's still quite ineffective to start from a randomly initialized neural field each time we see new patient data. So to address this, we also use a meta-learning strategy to learn an efficient initialization for our models. So we're essentially learning how to learn. So we start with this randomly initialized neural field with some parameters. And then we sample patients from a larger data set of patients. And we fit or optimize the neural field for that particular patient. Then we end up with a certain new set of parameters. And then we update the parameters of the base neural field with this update rule. So we're practically just running stochastic gradient descent on the model parameters. Doing this for a few thousand iterations gives us an initialization, which is a very strong initialization to start from. And that initialization looks something like this. So on the left, you see the tissue attenuation neural field sampled at 5 seconds. And you see that the contrast attenuation is still low. And this is also what we expect in CT perfusion. But when we sample it at 20 seconds, it's already a bit higher. And we also see similar structures for the cerebral blood flow neural field. We also do it for the arterial input function, but we're just showing these 3 here. Now, what do these 2 modifications, so this hash encoding and this meta-learning, now do in terms of convergence speed? So in this figure, the gray lines are representative of the naive implementation. This was a 2-dimensional approach without this hash encoding and without these meta-learned initializations. And we see that it takes quite a while for this tissue attenuation loss to actually go down. But when we use this hash encoding in blue, you see that we obtain a very fast fit for the volumetric CT perfusion data. And this allows already for perfusion map generation in about 12 minutes, as opposed to 40 minutes or so. Now in red, you see what happens when we use this meta-learned initialization. We obtain an even faster convergence and also more stable convergence in terms of the differential equation loss. So the main takeaway is that we use hash encodings to allow for volume-based fitting. And we use meta-learning to get an even faster optimization. So the first stages of optimization then look something like this. So on the left, you see our proposed methodology with the hash encoding and with the meta-learned initialization. In the center, you see the same model, but without this learned initialization. And on the right, you see what this model will eventually converge into after a few thousand iterations, or about 12 minutes. So when we then start optimization, we see that our proposed methodology very swiftly converges to a similar solution. I see that the video is not playing very nicely. That's a bummer. But trust me, after about 100 iterations or so, there we go. Okay. After about 100 iterations or so, it starts to become quite difficult already to see what really the difference is between this fully converged model and our proposed methodology. Well, for this model without this initialization, it takes much longer to even find the similar structures. So we use hash encoding to allow for volume-based fitting of data. And we use meta-learning to get an even faster speedup, allowing us to do this analysis in only 1.2 minutes. Now for the infarct core segmentation, we use a UNet on top of the cerebral blood flow map. So we trained this UNet using a small data set of patients that had both CT perfusion imaging at baseline, but also DWI imaging at baseline. And these DWI images were then segmented. So we trained this model and compared the performance to 2 commercially available software packages. And we see that we almost double the dice score, get a better volumetric agreement, and do not obtain any false negatives. So we're able to detect each of the infarcts. So there's many more visual examples in the supplementary materials of our paper. But for now, we propose these efficient neural fields for modeling blood flow in acute ischemic stroke. And with these hash encodings and meta-learning, we can do this analysis on a volume-based level within 1.2 minutes, which is fast enough for clinical practice. Moreover, we achieve accurate infarct core estimation, outperforming commercial software. So our poster session has already been, but I'll make sure to be around my poster during the next session as well. Thank you.
Thank you for the talk. Questions in the audience? Start with a question.
Sure.
You actually validate on segmentation dice, right?
Yeah.
Any chance you could also compare the perfusion values, or is it impossible?
Yeah, that's a really hard problem. So there's no real ground truth for perfusion data. So we can evaluate it on simulated phantom data. We did that also for this approach using the setup that I described before. So this method that worked on a slice-based level without these hash encodings and without this meta-learned. And there we showed indeed that this approach works very well for perfusion estimation. We got more accurate values, which were also more robust to noise. But yeah, there's no such thing as ground truth perfusion data, at least in CT. So yeah, it's hard to really evaluate it on a quantitative level, indeed. Yeah.
Thank you for your very nice presentation. I had a question about the generalizability of your method. Would you also be able to apply this on, for example, contrast-enhanced MRI scans?
Yeah, I think that should be no problem. A colleague of mine also worked on myocardial perfusion, for example, and there it also works quite well. Yeah.
Thank you.
one question over there.
Thank you for your presentation. I have a question about the hash encoding. First, how do you explain that, like, it decreases the smoothness of your field? Because if I remember, you said that it helps learning higher frequencies. And also, did you try other methods like positional encoding?
Yeah, so with the hash encoding, there's many ways to encode coordinates into higher space, right? So you can also use Fourier embeddings, for example. We also played around with those, but then you get some stripe artifacts which are potentially an issue. Hash encoding just works really well and really fast, and that's why we actually went for it. But what you say is true, so that's also why we apply it only on the spatial coordinates, not on the temporal coordinates, because we kind of want this high frequency detail to be in the spatial domain, but we kind of like the fact that it's a bit smooth in the temporal domain, because that's when this derivative is really nicely defined. So that's why we also just apply it to the spatial components of our model. Yeah.
There are no more questions. Let's thank the speaker again.
Thank you.
This actually concludes this session, so thanks to all the speakers. Thank you all for participating. Next is a coffee break and a poster session.
Okay, before you all go, please keep in mind to take down your poster at the end of today's poster session, please. Otherwise, we'll have to do it for you and you won't find it anymore.
peu, c'est pas grave. Enfin, de toute façon,
Je vais demander si quelqu'un peut le faire. Mais...
Ouais, ouais, non, bah après je suis là, moi ça me gêne, enfin, je pense à, enfin, je peux le faire.
Donc à faire automatiquement.
Oui, oui, ouais. Time, yes. Welcome back. Before we start the last oral session of the day, a few words about tonight's gala dinner. So it will be at the Musée des Arts Forains from like 7:30 p.m. Please be on time, otherwise you won't enjoy like the experience as best as it could. So you have the address there. It's also on the website and on the leaflet that we gave you. You can get there, you can walk from here, you can also use like public transports or use a bike. So here is a picture of like the entrance of the building, so don't miss it. And so yes, be there at 7:30, please. And so now is the last session of the day on synthesis, and so I let Jonas and Tolga introduce it.
Thank you very much. Yeah. So welcome to this last session of the day. My name is Jonas Riccardi. I'm in Lausanne University Hospital in Switzerland.
Tolga Taşizen from the University of Utah.
So our first speaker for today, the presentation is by Jixing Wu, IST editing, infinite spatial transcriptomic editing in a generated gigapixel mouse pup.
And so thank you for the kind introduction from the hosters. So here, I would like to first thank my amazing collaborators, Ingrid and Victor. Unfortunately, they are not here today, but this work cannot be done without their collaborative efforts. So now I would like to give you a brief introduction about our study, so-called IST editing. So before I dive into the technical details about our method, the first question I want to address is why? Why do you want to work on these topics in the first place? So actually, our motivation comes from causality. And actually, it has something to do with my previous causal inference background. And by the time I start to shift my research focus from general machine learning topics to biomedical research. So here's a sort of a conceptual causal graph, which may correspond to a concrete clinical question you care about. As you can see here on the left side, you might given some kind of genetic variables to be interested, and they are likely to causally link to the patient outcome. So in an ideal world, we would hope that we can directly implement genetic interventions on patient participants, because regardless of the outcome, they are the ground truth. But obviously, as many of you know, that it's not always feasible. Not only it's because of it's expensive under the randomized clinical trial settings, but also it comes with high ethical risk. So as a machine learning researcher, right, it's natural for me to ask, why not we perform it in an in silico way, right? And they work as a surrogate for the in vivo intervention, and they tend to be inexpensive, and more importantly, they have low ethical risk. Just a quick remark here. I mean, here, this sort of reflects our long-term or even ultimate vision of this topic, but we are not there yet. So before we really try to resolve this task, the first question we need to address is, so what kind of a data set could facilitate our vision here? So that's exactly the place where the spatial transcriptomics come into play. So here I would like to take a short pause and ask all of you to think about it, what are possible representations for a gene? Actually, this slide is sort of adapted from this impressive talk given by Professor James So. I would like to say thank you here. So there are at least 3 different ways. I mean, you could first treat the gene as a nucleotide sequence, right? And they are nothing but some kind of a foreign alphabet. Then you can use all kinds of a large language model to run on it, then perform the related tasks. Or you could take a canonical text description of a gene, right? Then you feed it to, again, a large language model to learn some useful features. Then you use that learned representations for all kinds of downstream tasks you care about. It also comes with a third way, which is you sort of link the gene expression levels to each of the cells. Then you come up with this sort of a gene versus cell tables. Then again, you can also use this kind of representations to try on all kinds of different downstream tasks. But as we all know here, biology happened in space. So in our case, our gene expression is actually an image, and more specifically, a multi-channel sparse image, which is actually profiled by the cutting-edge spatial transcriptomic technologies. And accordingly, our training data is the paired spatial gene expression together with the bioimage. And in the bioimage domain, actually, you can use all kinds of staining techniques to highlight the image domains, or it could be DAPI stained, or H&E stained, or immunofluorescence stained, or even protein barcode, if you will. So now I want to talk about some of the important aspects of our models that make this whole study work. So to begin with, we are inspired by generative AI. But I guess nowadays, who doesn't, right? And so in the generative AI settings, you usually would come up with a text prompt that describes the image you want to generate, or video, if you will. So in this case, it could be a jaguar with green eyes stalking prey. And then you will feed the text prompt to a trained model, then hopefully you could get the corresponding image content or video content you want. So in this case, I would say this mid-journey model is quite robust, and you did get corresponding images. So in our setting, the spatial gene expression is our prompt. So if you recall that the co-profiling, the co-profiling technologies developed by those spatial transcriptomics method. So on one hand, again, we have the spatial gene expressions, right? And then we can use that as the input, and hopefully we can also reconstruct the corresponding bioimages, which actually capture the cell or tissue, even organ morphology of the object you want to study. So here's some like the conceptual illustration of our models. As you can see here, I mean, it's nothing but a GAN. We use a GAN methodology. And the key component that make our idea work on even arbitrarily large size of bioimages that we introduce this so-called padding-free generator. Or more specifically, we exclude the padding for each convolutional layers so that we can at least impose the equivariance at layer-wise. So in this stage, we simply just feed the spatial gene expression as the input, and then we train model so that it can generate like visually plausible those non-existent like corresponding depth images. So once we have a robust model, then we can generate a whole slide images. And there's another critical aspect here. So basically, we use an so-called enlarged spatial gene expression or overlap the spatial gene expression input between the neighboring tiles. So by doing so, we can really impose this sort of a seamless generation of an ultra-resolution images without any stitching artifacts. So now I would like to show you some of the experimental results. So again, here, we take the spatial gene expression as the input, then we generate the gigapixel whole slide images of a mouse pup, and here is a DAPI-stained mouse pup. On the left side, you will see the ground truth images. And at this point, I hope you can recognize that it's indeed a mouse pup, and it contains all the important mammalian organs that humans usually have. And on the right side, we show the generation results. And for a side-by-side comparison, actually, I visualized the cell level as well as the tissue level for a more detailed examinations here. So I would say overall, we managed to reconstruct the whole mouse pup with good quality. So to further challenge our proposed model, so we also run the exact same experiments on the etching-stained images that profiled on the exact same mouth. Again, on the left side, you will see the ground truth mouth pup, and on the right side, you will see the generation results that we carry out. And in this case, I would say that our reconstruction quality is also reasonably okay. Yeah. So now we have this trained model in hand. Now we want to sort of carry out the so-called gene expression editing experiments. So here we actually select two sort of a region of interest for a discussion here. And I would like to have your attention on this specific genes called EpCAM, which means epithelial cell adhesion molecule. And it's just a epithelial-related genes. And here, actually, also, our experimental setting is quite straightforward. So we first narrow down to those regions of interest, and we filter out the top 4 leading gene expressions. Then we just sort of upregulate or downregulate the gene expressions, while simultaneously we zeroing out all the rest of the genes. So here you can see that in this colon region, you will see the gradual emergence of this so-called crypt epithelial structure. I mean, at this point, I really wish my colleagues are here. They're really the biomedical experts, but I just give it a try. And actually, it is indeed biologically meaningful. Why? Because they are epithelial cells, and they are highly relevant to the expression, or to the presence of the EpCAM. But another interesting thing you may see here is that is the missing muscle layers of the generated result. The reason behind that is because we simply zeroing out all the rest of the genes, including muscle-related ones. So that's why the muscle layer is not there. And so another interesting side effects of our model is that it actually can remove the artifacts. So here you can see on the right side, you will see the ground truth images, which contains this sort of unnecessary white stripes. Actually, by the reconstruction, we actually managed to remove that artifacts. So in the last, I want to talk about the rebuttal. So as many of you sitting here, I also went through the rebuttal process. We also get challenged by the reviewers. And here I would say, if you're here, our reviewers, I would say thank you. I mean, your questions are really legitimate. Yeah. So the first important question we were asked is why we run the training and testing on the same slide. Actually, this question I also got from the other audiences. It's very legitimate. But in our defense, it's like this, because to find this kind of data sets is very difficult, especially in our early stage experiments. Because in the end, we want to sort of showcase the feasibility of this kind of a research idea on the entire organism. And this kind of data is really rare. So that's kind of our difficult. Another thing is that actually we do run some like sort of a training testing split experiments on the very same slide. And we do keep some held out tiles extracted from slides and used for later testing. But I must admit that, I mean, we do run training and testing on the same side. But luckily, I mean, we are aware of this kind of issues at the very beginning, so we sort of actively looking for the potential data set candidates. And luckily, I mean, just late last year or around December, we found this interesting like nature paper that just released, and they actually provide 3 like very comprehensive like mouse brain atlas. So when I saw this kind of data set, I think it's very useful. So we eventually also run some follow-up experiments on that data set and also sort of address these specific questions in our rebuttal. So here I want to show you some of the generation results on this brain atlas. I mean, in the first row, you will see the ground truth like brain slides on the left side. On the right side, you will see the generation results. Also, in the second row, you will see the brain slide actually extracted from another mouse brain atlas. And also the corresponding generation results are also attached here. So you can see actually here, by the way, also we use the exact same settings for the models as well as for the training configurations. And I would say that, I mean, our generation results remains quite consistent. And then actually we run other experiments, and we basically switch the roles between the training data as well as the testing data. So in that sense, you will see the corresponding generation results. So to conclude, we take the spatial gene expression as the input, then we manage to seamlessly generate a gigapixel whole slide images of a mouse pup, and then by take the gene expression or edited gene expression as the input, then we manage to simulate cell, organ, and even animal level of morphological transitions. And lastly, I mean, the whole training and inference process can be run on a consumer-grade GPUs. Thank you very much, and yeah, please feel free to check our Git repository, and we uploaded our training data as well as the models. Also, the generated whole slide images can be visualized with the CubePath or commercial softwares. Thank you very much.
Thank you very much. We have time for a few questions. I'll get us started. One thing I'm wondering, so you showed results with, if I understand, down-regulating one gene, right? That you showed this example. But it seems to me that you have many traits that you would see in a staining that are probably polygenic, right? You would need to modify like multiple genes expression or down-regulate or up-regulate. Is this something that you looked at? How would you handle this in your framework?
So first of all, it's more like a proof of concept study. So basically, we tried all kinds of different gene combinations in this case. I wouldn't give any like a sort of a, how do I say? All I can say is that, I mean, when we look into the group of highly expressed genes, they usually would give us some biologically interpretable like morphological transitions. So that's sort of our main takeaways right now. And I think, how do I say it? I mean, in the end, I think this study needs to be eventually become more applicable. Then we really need to closely collaborate with the clinical practitioners and really like to come up with some very well understood like pathways or even single genes to really dive into deeper. Make some more deliverable outcomes. Yeah. No, exactly. I hope I answer your question.
No, very good, very well. Thank you. Thank you.
was really nice work. So you have mentioned that you use your model to generate the whole slide image.
Yeah.
I just wondering, have you ever evaluated the generated whole slide image quality, especially in terms of the cell features like nuclei, quality, etc.?
Yeah, definitely. Actually, that's a great question. I mean, we do run all the necessary quantitative measurements on our experience. Please just check our papers. You will see all the details there. But maybe another side comment on this topic. I think that's actually a challenge, actually, for this kind of topics. When we talk about how you sort of quantify the reconstruction quality of this whole slide images. Actually, it's not that trivial because the well-established those metrics are usually tailored for those generic images quality measurement. They are not really appropriate for these tasks. There are some further efforts need to be done. Yeah.
Okay, another question is, another quick one is, you claim that you use only one GPU to generate the whole slide image. I just wondering how long it takes.
I think it's around 40 minutes. Yeah.
Okay, thank you.
Okay, we don't have time for more, sadly, so thank you very much again.
Next talk is titled Generating Cerebral Vessel Trees of Acute Ischemic Stroke Patients Using Conditional Set Diffusion. And the talk will be given by Thij Coopers from Amsterdam University Medical Center.
Okay, wow, thank you for the kind introduction. I'm excited to be here and talk about our research on generating cerebral vessel trees. First of all, I would like to thank the University of Amsterdam's Responsible Digital Transformation Seed Grant for funding this project. Our personal disclosures are listed below. So, acute ischemic stroke is one of the leading causes of death and disability worldwide. And it is caused when a thrombotic occlusion reduces or interrupts the blood flow into a cerebral vessel. For the large vessel occlusions, the most optimal treatment today is the mechanical thrombectomy, where with a stent retriever, the occluding thrombus is mechanically removed. And as you can imagine, the type of vessel that it's being occluded, the type of device that is being used to remove the occlusion, or the type of thrombus itself has a really big impact on the success of the treatment. And that is also why stroke treatment development is still very much in active research. However, stroke treatment development is also extremely time-consuming and resource-intensive. But using simulations of stroke treatments, we can actually heavily or potentially reduce these resources that are required, as we can simulate many new treatments using in silico clinical trials and reserve the actual time-consuming real clinical trials for the most promising candidates only. And in the case of mechanical thrombectomy, these kinds of simulation treatment models have been developed and validated. But again, there is a problem. These simulations require large amounts of high-quality patient data, such as vessel geometry in the case of the thrombectomy simulation. And so that's a problem, because obtaining these large patient data sets is incredibly difficult. But there's a solution. Why not use high-quality synthetic data instead? So that is what we wanted to do. Our goal is to generate high-quality synthetic data sets of the large vessel cerebral vessel geometry, and we identify 3 important criteria that our data should satisfy. First of all, the synthetic data should, of course, be representative of the true population. Secondly, it should be unique, meaning it should not just copy from the true population, because, of course, that would be completely useless. And third, we should be able to generate our synthetic data conditionally, so we can generate very specific subpopulations. And in our case, we condition on healthy vessel trees and vessel trees that include an occlusion where the more distal vessels are not visible. So to obtain the data that our model is going to generate, we first segment CTA images of stroke patients from the Mr. Clean registry, from which we obtain the vessel segmentations. And next, as a very efficient representation of vessel geometry, we extract the center lines of the large healthy cerebral vessel trees and also the vessel trees where the occlusion occurs on the contralateral side. And we also mirror them, so they're always aligned. So our model is going to generate vessel geometry as center lines And the center lines consist of equidistantly spaced coordinate points, and each coordinate is associated with the radius, and also which vessel type that specific point belongs to, which is of course important because we want our model to generate a tree that contains different number of vessels, so it should also make sure that this tree is already kind of pre-segmented in a way. But we also want our model to be general, so it should be able to handle any kind of tree-like structure, regardless of the number of vessels that are in there or the number of bifurcations. And that is why we treat the generative process as a point cloud generative task instead, meaning our model doesn't have any prior knowledge on how points or different vessels are connected to each other. So this means that we represent our center line as a set of unordered points. So for that we need the right kind of architecture that can deal with this. And if we talk about unordered sets, then of course attention is all you need, and the transformer architecture is a really natural choice. And the transformer that we built consists of a series of blocks, and each block has a self-attention layer where point-to-point interaction can happen and the model can learn a global shape representation. And there is a cross-attention layer where we can inject conditional information to learn a conditional shape representation. And we want our model to be a generative model, and that's why the model is tasked with a denoising diffusion objective. So we add noise to the input coordinates, input radii, and input vessel types, and then during training the model is tasked to denoise these samples, and then during sampling we can simply initialize from a unit Gaussian the coordinates, radii, and the vessel types, and then iteratively denoise it to produce a synthetic sample. So that is really nice. However, since we assume that the input is unordered, the output center lines that we generate from the model are also unordered, which is undesirable because we actually need this tree structure that we had in the beginning for downstream tasks, such as meshing or calculating different geometric characteristics of the vessels. So that's why we have a post-processing step where we reconstruct this tree-like structure. And since the input point clouds that the model is trained on are spaced equidistantly, if our model does a good job, we can kind of assume that the synthetic vessel trees are also spaced equidistantly. And this really simplifies this process since we can use some simple nearest neighbor averaging and thresholding. So first, we start for each individual vessel segment in the tree by detecting the starting point of this segment. Intuitively, you can kind of see that this is the point where all of its neighbors are in kind of the same direction. So if we consider a point that is in the middle of the sequence, then the nearest neighbors are in opposite directions, whereas a point that is at the start of the sequence, all its neighbors have a very similar direction. And then once the start of the segment has been found, we simply iteratively add points to it using the nearest neighbor distance, and we also take into account the direction that the vessel moves in. And then, once all the individual segments have been formed, again using nearest neighbor distance, we can find their intersection points and merge the different branches and form the final tree. So, once that has been done, to evaluate the quality of the synthetic vessels, we generate a data set that is roughly, a synthetic data set that is roughly the same size as the data set that the model is trained on. And recall that we want our synthetic data to be representative, unique, and it should also be conditionally generated. And to do that, we're going to compare different geometric characteristics from the synthetic data set to these characteristics from the real data. And I also like to point out that during the creation of the synthetic data set, there were 7 cases where the model failed because it produced too much noise in the center lines, so we could not reconstruct the tree-like structure, and we exclude these 7 cases from our. So let's start with just looking at some of the vessels. At the top, we can see the vessel trees belonging to the healthy vessel trees. And at the bottom, we see the vessel trees where an occlusion occurs, so the more distal vessels are not visible. And after analyzing the synthetic samples, we found that the model always correctly assigns the right geometry corresponding to the given input condition. So the model indeed has learned a fully conditional shape representation. Nice. And as a bonus, it always assigns the correct vessel type to the individual points, so it doesn't confuse the different vessels that are in the tree. And next, we want to look at, are these synthetic vessels actually representative of the true data sets? So what we did is we calculated different geometric characteristics of the vessels, such as tortuosity, average radius, and bifurcation angles. And we compare the distribution of these characteristics between the synthetic data and the real data. And we look at these distributions and we see indeed a very similar pattern appear. So this kind of suggests that the model indeed produces synthetic data that is representative, which is really nice. However, these visualizations alone don't really tell us how significant these similarities are. So that's why we also wanted to perform a quantitative analysis. So what we did is we used the Kolmogorov-Smirnov test to calculate the difference between these geometric distributions. And in this case, I'm showing the differences for the tortuosity statistic on vessel trees with an occlusion. And what we see is if we compare these differences between the real and the synthetic distributions, on the diagonal, where the same vessel types are being compared to each other, we see there's a very low, insignificant difference, which is exactly as expected, since these vessels should, of course, be very similar. But actually, if we look at the off-diagonal entries, we see something interesting. We see that there is a very highly significant difference in the vessel geometry between the different vessel types within the tree. And if our model has actually learned a representative representation of the true data set, then we would expect to see a very similar pattern of differences between the different vessel types within the true data set. And indeed, if we compare the vessels within the true data set, we see almost exactly the same pattern. So this indicates that the model has indeed learned a very nice geometric representation that is representative of the. But of course, if the model were just to copy from the true data, it would also be fully representative, so we need to make sure that that is not the case. So what we did is, for each synthetic vessel, we found from the real data set the vessel that has the most similar shape, where we measured this similarity using the chamfer distance. And what we observed is that the generative model would always generate a vessel that is really unique compared to what is present in the training. So it does not just copy from the training data. So with that, we can conclude that we generated a synthetic cerebral vessel geometry dataset that is representative of the true dataset that it was trained on. It uses samples that are unique, so it does not copy from the true dataset. And the representation is also conditional, so you can steer the generative process. But stochastical analysis does not tell the whole story, so that's why we want to validate the synthetic vessels on in silico thrombectomy simulations. And finally, to improve the generative process, we want to condition on patient demographic variables. Thank you.
For the nice talk. Questions from the audience?
Thank you very much for the nice presentation. I have a question with respect to the actual acquisition of images. So as far as I understood, you are getting the geometrical representation of the vessels, right?
Mm-hmm.
And do you plan, and if you plan, how would you integrate it into the images?
So you're asking how we want to integrate these geometric shapes that we generate into the images?
Exactly.
So we're not planning on doing that, as far as I know. So what we want to do is use these vessel geometries that we generate on these treatment simulations.
Okay, I see.
So we really don't need to go back to the images, but we have been thinking about, because of course we would like to have more data that we can use to train these models. So we've been thinking about, can we actually use these generative models, because they learn some form of shape prior, to maybe help the segmentation models find the kind of shapes in the images that we need.
And have you explored the latent space, or have you tried performing the interpolation in the latent space to model some pathologies, or you are controlling it exactly only with the input condition?
Yeah, we're currently only controlling it with the input condition.
But do you have any ideas about like interpolating in the latent space?
No, not really. I mean, I've of course interpolated the latent space just to see what it looks like, and then you see like the vessels change nicely. But apart from that, I haven't really explored that yet.
Okay, thank you.
Yeah. Thank you very much for your presentation. It was really interesting. Is there any reason why you are just focused in M1, M2, ACA, and the other one, I don't remember the name? And if not, you think it could be extended to more distal veins like M3 or M4? Thank you.
Yeah, so right now we don't really have the segmentations for the more distal vessels. And we also wanted to focus on the occlusions that occur in the large cerebral vessels. So that's why we focus on these specific vessel types. But we definitely do want to expand the generative process to generate bigger, larger vessel trees, especially the more distal vessels as well.
For one last question.
Well, I have many questions, so I'll just thank you very much for your presentation. Have you checked that your trees obey the phenomenological laws associated with vascular trees, such as Murray's law?
I'm sorry, I couldn't really understand the question.
When you generate a tree vessel trees, they don't grow. They obey laws, especially at bifurcations. For example, the way trees and actual trees and any vascular tree, even roads, are constructed. Most of them obey a law which is called Murray's law, which is a law that connects the diameters of the incoming vessel with the outgoing vessels. So it's a very well known law, and it's well respected in the trees that are associated with organs. So for example, in the hearts, in the liver, or in the brain as well. And it's very simple to check. I don't know if you have checked it.
Yeah, I know. I'm sorry. I really cannot understand anything you're saying from back here.
Okay.
But maybe we can discuss.
Okay, I'll do that
later.
Okay.
Okay, so in the interest of time, we should move on to the next talk. But let's thank our speaker again.
Thank you.
Yeah, our next talk will be by Hadia Yassin, evaluating age-related anatomical consistency in synthetic brain MRI against real-world Alzheimer's disease data. And the floor is yours as soon as the slides are up.
Thank you for the introduction. My name is Hadia Yassin, and I'm the first author of this paper. So today I will be advocating to move towards tailoring evaluation methods when we're assessing medical synthetic images. Medical field is a very sensitive and high-risk field, and we always, even in regulatory, we always have more stringent evaluations. And in our case here in our group, we synthesize MR images, and our application is Alzheimer's disease. So our motivation comes from the fact that we have so many limitations in traditional evaluation methods. Some of you already mentioned that. And so if we look at traditional evaluation methods, they normally compare two images, real and synthetic, as a whole, right? And whether it is FID in image space or SSIM with a direct pair, or even visual Turing test, we are always comparing the whole image or a direct pair. And unfortunately with that, especially in Alzheimer's disease, we are missing valuable information about individual anatomical structures. So what happens to our brain regions through the progression of Alzheimer's. And also we are missing, we are missing temporal context. So the whole depth, or the whole dimension of age, we're not looking into that when we are directly comparing. Visual Turing test is a little bit different, right? So we give an example like this to the radiologist and ask them to distinguish between real and synthetic. The problem is here we might get some individual anatomical context, and the radiologist might be able to pick up on patterns between the real and synthetic images, but I would emphasize they might not, because it is super subjective depending on the person undergoing the test, right? So their experiences, their biases, and it's also subjective depending on us, the ones designing the test, and if we have representative data or subset from our huge 600,000 generated images. And of course, they cannot go through this much images because it's infeasible for them. So we need to tailor an evaluation method to this task. And I know some people think of this as negative because it's so specialized, but for me, I think it's the way to go. And because we're trying to have some quantitative method that is objective, like the FID and SIM, but at the same time, provide individual anatomical and temporal context. So how do we tailor evaluation methods? First, we have to understand the task at hand, which is AD. Then, of course, understand how the generative models was developed and how they tackle this task. And finally, we develop our tailored evaluation method. So if you look at Alzheimer's disease, on the left side, you have the normal brain. And if you see, the right side is a brain affected by Alzheimer's disease. And as you can see, the brain shrinks in general. And if you look in the middle, we are here focusing on two brain regions, the lateral ventricle and the hippocampus. The lateral ventricle on the right side, it increases with age. And on the top left, hippocampus shrinks with age and Alzheimer's. So now that we understand the task, our generative model that was developed in our group promises us, or the claim is, that we'll get realistic 2D coronal mid slices that mimic brain changes with age and progression. And our generative model is based on a conditional style GAN3 plus a causal model. The causal model is represented here in this DAG. And basically, we have those covariates, age, sex, they affect the cognitive score in the middle, which gives us, of course, how far is our, the progression of Alzheimer's disease, whether it's cognitive normal, mild cognitive normal, or AD. And then here, so our causal model understands this relationship between the covariates and gives plausible 4 labels to the conditional model while training, and then this guides the learning, and in inference time, we can use this causal model to generate the images with specific covariates, of course. In this presentation, we are focusing on the age variation aspect. And it's really important to know also the scheme of how the generative model was trained. It's basically based on transfer learning. And as you know, UK Biobank is a very famous data set. And we first trained on that and then fine-tuned on the ADNI. Why? Because obviously UK Biobank is large, right? Way larger than ADNI. And we learned first some attributes from UK Biobank. And if you see here, UK Biobank is more of a general cohort. It is more inclined to be healthy. And ADNI is AD cohort and it has labels for Alzheimer. And finally, as you can see as well, naturally, UK Biobank has a younger age population mean of 55, and UK Biobank an older population of 74. Okay, so when we want to develop our evaluation method, we want to try to provide 2 things. One thing is we want to provide context on temporal changes in the anatomical structures, the hippocampus and the lateral ventricles, and also we want to give more global comparison based on those hallmarks and not a direct comparison between pairs. So if you see here, this is a very simplified graph about how the areas, if we segment them from the brain, how they would behave. In lateral ventricles, they will enlarge. In a hippocampus, they will shrink. And we're hoping that the synthetic images we produce follow this natural trends. And if this is correct, or if we can observe this behavior, we say that if we have two subsets, so real and synthetic data, and they are sampled from the same covariate distribution, so they have the same ages, and theoretically speaking, if we plot the areas we segmented, they shouldn't be significantly different, or that's what we're hoping for. For statistical testing here, we're showing the permutation test results. As for the methodology, we have two experiments. So the first experiment, we, as I said, resample from the 600,000 images we have, two subsets, real subset and a synthetic subset. But meaning that they would have the same median age, so all of the image, so if we have 5 images that are 6 years old, from real we'll have the same from synthetic. And then we quantify the areas. Here is the lateral ventricle, for example, using a in-house developed deep learning segmentation model. And then we get the distribution, hoping that there's no significance. And the second experiment is that we deliberately change only the distribution of the the synthetic data, meaning that the real data would still have the same median age of 74, but if you look at the synthetic, it has more counts of people or subjects that have here, for example, younger age by -3, so they would have an age of 71. And here, of course, we hypothesize that we should definitely see a difference, a significant difference, because it's coming from two different populations. But to our surprise, actually, if we look here, this is first the matching experiments for lateral and hippocampus, and on the sides are the deliberately mismatched. And if you see here, we have the statistical results. Unfortunately, if you look at the hippocampus first, in the match, we don't really have any significance, right? But it's very close, super close to significance at 0.057. But if we look on the left, when we subtract -3 years from the synthetic subset, we're actually far away from significance. So this is actually not what we were expecting. +3, of course, we have significance. We were expecting that. But if you even look at the ventricle, it's even worse. So for the match, we actually have significance. And again, for -3, we are far away from significance. So if we look closer at those match examples, and we look here on a finer grain plotting with the ages, right, we are looking for two things here. First of all, as we talked about it before, we're looking at the age trends. So good news, right? The lateral ventricles in the synthetic, in the orange, are following the areas of the real in blue with age, so they're enlarging, and the hippocampus is shrinking. But then also we have to think about the discrepancies, because we did get significance in lateral ventricle and close to significance in hippocampus. So if we look at the extreme or more discrepancies in some age bins, I highlighted those. And if you look first at the hippocampus, they are more towards the sides of the ages where we have less subjects. That's the first thing. But in general, it's kind of 50-50 in the hippocampus, so there's good representation of the hippocampus, better from our generative model than in lateral ventricles. In lateral ventricles, we actually have discrepancies in each one of those. I just highlighted the ones that look with higher discrepancies. And if you look here, the generative model seems to overestimate the enlargement of lateral ventricle with age. So always the synthetic images have higher areas than the real ones. And finally, the last thing is also we wanted to see if we have any compromised structures that are a no-go. And unfortunately, it's not a big part of our data, but 0.82% of the synthetic areas have a very small, unusually small ventricle size. If you look at the one on the left, it's a synthetic image, and it has so small ventricles that it's not even plausible for an adult or even a baby, right? So this is really dangerous. And actually, a female with the age of 81 and mild cognitive impairment would actually have any of the other two ventricle sizes. So this would actually, like, if this ever gets to the clinic, this will actually introduce an unrealistic bias that we never ever had in any data sets. To conclude, so our traditional method provides some context on the temporal change to anatomical structures. We are looking at more global comparison of the AD hallmarks, and we can pinpoint some areas of improvements, especially on the age axis, and then hopefully we can improve our generative model and check again and see if anything changed. Finally, the future work would be to adapt this method to another imaging task, maybe tumor progression. So if anybody synthesizing tumors and wanna see, we just have to adapt our segmentation models to the tumors and see if we are preserving the same patterns in tumor progression. Thank you. I would like to thank my co-authors and our project partners, and I'm open for your questions.
Thank you very much for the talk. Let's open it to the audience. Please raise your hand if you would like the microphone.
Hi, thanks very much for your presentation. Could you go back to slide 6, please?
Yep.
Just out of curiosity, what causes the decrease in lateral ventricle size and the increase in hippocampal size at like the very right end of both plots?
Oh, that's definitely, yeah, that's really interesting. I actually wanted to also look at it. To be honest, normally when you show this kind of results, you also stratify on the different progression categories. So you normally don't do it for the whole area. So you do it for MCI on a side, and for Alzheimer's disease on a side, and for cognitive normal at a side. And of course, I don't remember which one of them. I think it was AD, because as the further we go with the age, we have way less labels for ADs. So I think that's maybe what is causing this a little bit weird behavior. But if it was stratified, you would see exactly which ones is contributing to this one.
Basically, they're outliers, you think?
I think so, yeah.
Okay, thank you.
Hi, just a quick question. So generative modeling of brain data has been going on for quite a while. There's actually quite a large amount of work already happening on estimating volumes from generated data, even doing voxel-based morphometry and much more advanced morphological analysis of generative outputs. Could it be that some of the negative results you're presenting here are a consequence of your model being 2D rather than 3D?
Oh yeah, definitely this is a big issue. I mean, the thing is, so my work comes after my colleagues' work, right? So by the time for MIDL, we didn't have the 3D model yet. So the actual trajectory is after you finish with the 2D proof of concept, then you will move the same concept to 3D and still preserve the conditional style guide and the causal model. So this is an open question, and hopefully it would be resolved when we have the 3D model, or at least some indication of it.
A final quick one, if there's one. Oh. Okay, let's thank the speaker again. Thank you very much.
So the last talk of the session is titled Medical Diffusion on a Budget, Textual Inversion for Medical Image Generation. And the talk will be given by Bremda Wild from Radboud University Medical Center.
Thanks for the introduction. Also, thanks all for still being here today. Well,
or I should say this afternoon. Yeah, so we'll look at diffusion models for medical imaging. Basically, I'll show you that with just a few images, you might already get quite some good results. So first, to introduce the diffusion models. They're really popular for text-to-image modeling nowadays. We already saw a few examples also, I think. So in my presentation, I will focus on stable diffusion, which I think is one of the most popular ones, mostly due to, I think, two aspects. One, that it's open source, and also that inference is relatively cheap in the sense that you can just do it on a single consumer-grade GPU. I just put some example generations here, just for some fun. This website I highly recommend to check. This is a guy who makes selfies with like historical figures. So a problem with diffusion models, if you want to train them from scratch, is they require a lot of compute and also a lot of data. Whereas in the medical domain, you might not have both of them. So you can have rare diseases, which only have a few cases. And local compute in a hospital is also typically not huge data centers that Stable Diffusion was trained on. So we wanted to see, can we generate prostate MR images, for example? So first we wanted to look, does Stable Diffusion actually already know medical imaging? So we asked, for example, you give a prompt, give me a prostate MRI scan or a T2-weighted MRI scan. And you can see that the generations really don't make sense. So you maybe get something that resembles somehow medical imaging, but it's nowhere close. So the insight was kind of, we need to fine-tune towards the medical domain. Now there's various methods you can use to fine-tune diffusion models. Also in the presentation, the very first one this morning, for example, low-rank adaptation is a popular one. The various methods fine-tune different subparts of the diffusion model, and we chose textual inversion, which essentially only trains the token embedding. So here in the diagram, you can see kind of an overview of a latent diffusion model. And so basically the denoising unit that you can see is conditioned by a text embedding. And so if we want to introduce a new concept to the model, we can give a few examples and basically prompt the model with the examples and then only train the text embedding and leave the entire model fixed. So yeah, we tried it for a few different modalities. So just to give you an example of the original publication, so this is something you can give it, for example, 3 examples of a teacup. You call it the token, in this case it's called S, and then you can kind of flexibly prompt. So you can say, I want a manga drawing of this thing, or I want it to look like the Death Star. So you can really introduce a new concept and still use your text prompting. So this is actually the way this project started. So this is my cat, Shelly. Honorable mention. So you can actually teach the diffusion model who Shelley is, and then once you've done that, you can prompt, for example, I want a painting of Shelley as a knight. I think that I did this. Okay, so but we want to explore seriously. Can we also do this for medical images? So the original work uses small embeddings and also only like a handful of examples and show that you already get good results. But we found when we first started trying that actually for medical images that seems to be not the case. So you can see all the way on the left column, that's kind of the typical textual inversion setting. And there you can see that, especially the bottom case, if you give only 5 examples, that is really bad. And we found that, let's say, up to 100 samples or so, you can start to get actually really good results. And the same goes for this embedding size. So that's kind of the amount of words you give the Stable Diffusion model to represent your concept. So then we wanted to look, can we somehow see if the generated images, if they are somehow faithful, if they're diagnostically accurate. So we set up a really simple classification experiment. We trained prostate MRI embeddings only in 2D, where we encode different modalities as RGB channels. And we train negative and positive embeddings, so 2 embeddings on 100 cases each. So as I said, we encode the 3 modalities, T2W, ADC, and DWI as RGB channels. And then we essentially train a ResNet 18 to predict if there's cancer, yes or no. We use a 200 case train validation test split. So the point is not to get really good performance, but rather to see what happens if you start to add synthetic data to the setup. So we found three things. So here you can see in the first row, if you train just on the 200 real cases, you get some AUC. In this case, it was 0.78. For prostate MRI, we found that if you then add a bunch of synthetic cases, you can actually improve performance maybe a little bit. For some other modalities, we didn't necessarily find the same improvement, but also not a degradation in performance. So that's nice. But then also what was more interesting is that if you now leave out the real cases, so you train only on the synthetic data, you can see that performance drops only maybe by 1 or 2%. So to us, that kind of implicitly indicates that the generated images are faithful, because otherwise the classifier would not be able to distinguish. And that's kind of confirmed when we repeat this, but then, oh, this is messed up a bit. So if you train embeddings only with 10 cases, then you get actually really bad images, and you can also see that then if you train only on synthetic data, the classifier also almost refers to a random classifier. All right, so we also compared to some GAN baselines, so we just also saw StyleGAN 3. That's actually what we compared to. So what we did is we fine-tuned a pre-trained StyleGAN 3 also on 100 images, and we kind of matched the training time and compute that we used for stable diffusion fine-tuning. So here you can see two examples, and we gave basically these kind of blind, here they're not blind, but blind A/B tests to a radiologist. He preferred the diffusion model and also noted that most images are actually quite fine. But also on the other hand, the StyleGAN 3 generations were also not that bad. So I think in general, what you can take away from the talk is that maybe just with fewer examples than you might think, you can actually get accurate generation. All right, so then kind of to close off, I want to show maybe what can you do with it, right? So you can just generate images as is. But because you have a text-to-image model and you have now these embeddings which you can use in prompting, you can also do some more interesting stuff. So one thing is you can compose embeddings. So to illustrate, you can, for example, interpolate between a healthy and a diseased state. So for that, you can train, for example, two embeddings, one healthy, one diseased. So you would give 100 healthy examples, 100 diseased examples. And then you can prompt the model something like I want 30% healthy and 70% diseased. And so for cardiomegaly, for example, on chest X-ray, you can see that the heart kind of grows as you go from left to right, as you increase the disease state. Similarly, you can also use this to combine multiple embeddings to show multiple diseases. So not interpolate between healthy and diseased, but actually try to show two diseases at once. So here we did pleural effusion and pneumonia, for example. So in this image, you can see that progressively from left to right, we add a new disease. So you start healthy, you add the pleural effusion. The pneumonia, I think, is not very visible. And then finally, you also add the cardiomegaly. I should say this is kind of like an initial try, so we haven't really validated this properly, but it's kind of nice that you get this for free just by the fact that you train text embeddings. And then I think a final thing to show is disease in painting. It's also can be really useful. So there you essentially mask a part of your image and then only denoise on the masked part, and that can give you more precise control over the disease location. So here we have an example. In the top row, we have a healthy prostate MRI. And then on the left, you can see on two places we inpaint. And then what we do is we condition the model on the diseased embedding. And then if you inpaint, you basically only allow the diffusion process to happen in the masked part. So the diffusion model tries to end up with a diseased image. So it will generate a tumor kind of in your masked location. That's the idea. This also seems to work. So you can see in the T2, it gets a bit darker, and also in the DWI, you get bright spots indicative of a tumor. So you could use this, for example, to generate diseased cases where you really want to control where the tumor appears or any other abnormality you might have. Okay, so that actually already brings me to the conclusion. So yeah, I think the main thing to take away is you can actually fine-tune Stable Diffusion with maybe at least 100 images. I think we have shown that they are somehow diagnostically accurate. Of course, it's difficult to show really precisely if they're completely real. You can also compose multiple embeddings and use in-painting for disease appearance. So you can use also this as a kind of fancy data augmentation or curate some kind of synthesized data set. And then for future directions, I think it would be really interesting to fine-tune actually a medically pre-trained diffusion model. Because the diffusion model we use now was pre-trained on natural images. So you can imagine that with a medical diffusion model, maybe you need even less examples. The method we use, textual inversion, in principle should be applicable to 3D models as well. So if you would have a 3D diffusion model pre-trained, this should apply equally well. Yeah, as I mentioned in the introduction, I think it could be interesting to study this in cases of rare diseases where you really cannot obtain thousands of scans, but maybe you really only have 100 in your hospital system. Yeah, and then finally, see if you can really get some gain from using this composing and in-painting to improve your results. All right, with that I would like to close, and I would say if you're interested, please try it out. You can scan the QR for the code, instructions, etc. Yeah, and I'm happy to answer any questions. Thanks.
For the very interesting talk.
Thanks for the talk over here.
Yeah.
Can you somehow convert, are there ways to fine-tune the latent diffusion model such that you can make use of 3D images or convert a 2D trained stable diffusion model into a 3D version?
So if I get the question, you ask if you could also do this in 3D, is that right?
Yes.
Okay, yeah. Yeah, so I think the main reason why, or at least why we didn't do 3D yet, is because we wanted to fine-tune. So we just took, let's say, the standard stable diffusion, which is trained in 2D. If you would have a diffusion model that's trained in 3D, then actually the exact same method should apply, because you would have a text-conditioned 3D diffusion model, so you could still train new text embeddings. So I think the easiest way to try if that would work, maybe take a video diffusion model and actually use that maybe to yeah, to fine-tune to medical images. Or perhaps there is actually a medical 3D diffusion model also out there, but I'm not aware yet.
Thanks.
Thank you very much for the nice presentation. I have a question. Could you go please to the slide with the in-painting?
Yep, sure. Yes.
So have you evaluated the realism of these cases? I mean, like, for example, if you provide these black spots as a condition mask, potentially sometimes it could be, there could be non-realistic interpolation between the tumor region and the original non-altered part.
Yeah, it's a good question. So we haven't done proper validation with these extra cases. It's more just to show the idea, but I think also, for example, if you mean you might get a really sharp boundary because of your mask.
Exactly.
So you can actually also soften that a bit to decrease that effect. So I think that's in principle fine, but what we did also see is that it still depends a bit, of course, if it's in your training example. So if I would want to generate a tumor in a location that's not in any of the examples, I think that might be much more challenging. So something weird might happen there if you force it to still generate a positive case.
I see. Thank you.
Great talk. I have a similar question. So is this the only way that you can control precisely the location?
So in principle, the diffusion models in general, you can also condition on a mask directly.
Mm-hmm.
But then you would need I guess a
so
different
how about
model.
just giving a seed or something like a control net or something like that?
Yeah, I think that should work too.
But you haven't tried this yet?
I haven't tried this yet. Yeah, another thing I was thinking that might be even easier is just to, because now we did the modalities in our RGB channels. You might even put the segmentation mask as one of the channels and then have it learn the segmentation mask and the image like at the same time, and then denoise with a given segmentation mask. Maybe that could.
Okay, thank you.
Last question, maybe.
Yep. Thank you for your talk. Can you please go to the slide with the downstream task results? Where
Sorry, that?
Can you please go to the slide with the downstream task result declassification one?
You mean this one?
Yeah.
Yeah.
Can you please elaborate on where the test set came from, and did you investigate the generalizability of your method on the data set out of the general training distribution, let's say? Because I assume that it's the same data set, the same manufacturer, for instance, and I just wonder whether this applicable and would improve the results on the images from the other manufacturers, from the other test distribution.
Yeah, good question. So these, let's say, we used 600 real cases, which we split 200, 200, 200. So the 200 train we also used to train actually the embedding. So that's really the only training data, to put it that way. But this data comes from a prostate MRI cancer detection challenge, PCI challenge, which has some 1,500 public training images. I must confess I don't have out of the top of my head if they're all same scanner, or there might actually already be a variety in there. But you're right, so we just took one data set and then split inside there. We didn't investigate external test set or so. So as I said also, our goal was not to reach, let's say, really high AUC here, because I think also you could easily improve on this 0.8, but more just to investigate in an indirect way how valid the generations are. Yeah.
All right, thank you.
Okay, thank you. Let's thank our speaker again. That concludes the session. Thank you all for attending and the lively discussion.